My name's Alan Weil. I'm Editor-in-Chief of Health Affairs. We're really pleased to have you here for the briefing of the release of the March 2017 issue, focusing on the topic of delivery system innovation. If you're here and if you're a reader of Health Affairs, this topic probably needs little introduction. There are efforts underway in the public and private sector by payers, by providers, by consumers, by everyone in the healthcare system at this point to try to figure out how to deliver care more effectively, more efficiently, lower cost, better quality, better coordination, better patient focus. And all of that is terrific. The question is, does any of it work? And if it works, what makes it work? If it doesn't work, what's not working about it? And by the way, what does working mean anyway? There are many dimensions along which we're seeking improvement in the healthcare system. Value seems to be the watchword, but value is often not particularly well defined. And so it's really a privilege to put together an entire volume focused on the question of what's going on out there, what do we know about it, how can we understand the context in which it occurs. And this issue exemplifies what we really love to do at Health Affairs, which is both set the stage, talk about broadly the environment in which innovation occurs, look at specific innovations across various different topics and sectors and populations, and try to report the latest understanding of the effects of those, and to look at the different actors in the system, who's promoting, who's trying, who's measuring, who's studying. All of that comes together in this issue. We, of course, publish on this topic really pretty much every month, but it's a unique opportunity to pull it together, and we're very proud to be able to do so. This issue, like many, has a few additional features. I just want to point you to two of them. One, by now you've probably seen, we try when we have a thematic issue to present a single-page data graphic that captures some of the findings from the issue, as well as sometimes draws on evidence taken from other sources. But you can never summarize everything that's in one issue of Health Affairs, but it's our effort to capture some of the key findings around delivery innovation. In addition, in the March issue, it's the first of our new Eye on Health reform, which is taking our most popular blogger, Tim Jost's, almost daily, sometimes hourly work to keep us all apprised of what's happening in health reform and pull it together on a monthly basis, releasing it first on the web and then including it in the March volume, and we'll continue to do so in future issues as long as we're doing health reform, which seems like that might be a while. I want to acknowledge the hard work that it takes to pull together an issue like this, in addition to our funders who are listed here, and I want to call them out not just for their financial support, but also for their intellectual contribution that makes an issue like this possible. We received support from the Blue Shield of California Foundation, the Colorado Health Foundation, the Missouri Foundation for Health, and the New York State Health Foundation, and their support makes this issue and this event possible. We're also doing an event in California in a couple of weeks with a discussion of some of these papers as well. I want to acknowledge Jamie Robinson at the University of California. When we do a thematic issue, we have an advisor. He was our advisor who helped usher this issue through, and we're very appreciative of his support. So today what we're going to do is walk through some of the papers, many of the papers in the issue. Our first panel will look at the context, promoting innovation, measuring innovation. We'll turn to a panel that looks at a variety of aspects of commercial health insurance and benefit design. After our break, we'll look at Medicaid and the safety net and innovations in the Medicare programs. As I say, one of the joys of putting a comprehensive issue together is that we get to look across all of those different settings. You can slice and dice this by population, by payer, by provider type. There's no right way to do it, but we try to organize the content in a way that's accessible. So without further ado, let's hear from the authors whose work you came here to learn about. And our first panel is going to discuss promoting and measuring innovation. You'll hear from David Bates, Chief of the Division of General Internal Medicine at Brigham and Women's Hospital, Medical Director of the Clinical and Quality Analysis at Partners Healthcare, and an expert in patient safety, information technology, quality of care. Also a professor of medicine at the Harvard Medical School and professor of health policy and management at the Harvard School of Public Health. You'll hear from Mark McClellan, a member of our editorial board. I don't need to say any more, but there's much more to say. He's director of the Duke Robert J. Margolis Center for Health Policy and the Robert J. Margolis Professor of Business Medicine and Health Policy at Duke University. We have known him for his time at the Brookings Institution as well as at directing CMS and FDA. We'll hear from Anna Sinaiko, research scientist in the Department of Health Policy and Management at the Harvard School of Public Health, and Kevin Smith, senior research public health analyst at the Center for Advanced Methods Development at RTI. So let me turn it over first to David.
Thank you, Alan. I'll be talking about innovative environments in healthcare and where and how new approaches to care are succeeding. And this work was done with Aziz Sheikh and who's from the University of Edinburgh, David Ash from the University of Pennsylvania. There are a number of key factors that organizations need to pay attention to if they want to promote innovation. These include providing, of course, money and physical space to enable it, but also coordination and consultation around areas like intellectual property and licensing, which medical providers may not know about. In addition, it's critical to provide access to people with disparate skill sets, like access to engineers, software designers, behavioral scientists. Another key factor is making both providers and patients available to innovators. Often innovators have a hard time getting in to healthcare. It's critical to have a long-term view. It takes a while for innovations to be developed and to succeed. And then finally, any innovation group has to be insulated from operational demands. If they're asked to do operational things, they'll get eaten up. Alan has just described why innovations are needed. I think this probably goes without saying, but the costs of healthcare in this country are too high. The quality could be better. If we had innovations, that could help with diagnosis, with therapy, with self-care. You'll be hearing about all of those from other presenters later today. And healthcare has lagged other sectors. The notion is that accountable care and bundled payments will accelerate progress around innovation and promote investment in these areas. Now, innovation is going on both inside and outside of academia. And in this paper, we elected to focus on what's going on within academia. There are not robust statistics about this, but at one point, there were about 15 innovation centers that were identified in a relatively unscientific survey, and then just a couple years later, 67 were identified by the Commonwealth Fund in 2011. And an exact count isn't clear, but it seems like these are springing up like mushrooms. They have three main areas of focus, drugs, devices, and digital technology, although there are other areas that get covered too. Now, a lot of important innovation does occur outside academia. I won't focus on that in the rest of this talk, but there are investors like Rock Health and HealthBox that are doing very innovative things. Blueprint Health and Avia, which is a network of major systems that's come together to promote innovation. And there's the example of Israel, which has been called Startup Nation. They've done some things which have been extremely successful at promoting innovation. They set up innovation zones with tax advantages. There's space for startups. They're located near engineering schools, and they have federal money through competitive programs. And if you look at the startups that are doing well in this country in healthcare, a remarkable number of them come from this tiny country. Next, I'm going to go through a few of the leading innovation centers in the U.S. And we could have picked any one of a number, but these are the ones that we elected to focus on. They vary in terms of their focus. Some of them have more of an external focus, and by that I mean developing innovations that could be commercially valuable. And some have an internal focus, and by that I mean improving care in the organization. So the ones we picked were Cleveland Clinic, Geisinger University of Pittsburgh, Mayo, and the University of Pennsylvania. Cleveland Clinic, for example, has developed a process called an invent. This is the idea is to take products to commercialization, and they focused in particular on new devices and health IT innovations. The University of Pittsburgh has taken a somewhat different angle. What they try to do, in particular, they do many things, but they try to find small companies that they can co-invest with and co-develop with. One example of a success like this was a company called DB Motion, which takes data and makes it possible to move it all around your system. That worked very well, eventually sold for $235 million. Geisinger has invested very heavily in improving their care processes, and then they spun off an entity called Proven Care, which sells its care improvement tools to other organizations and gives you essentially roadmaps for redesigning your clinical systems. Mayo Clinic's focus has been on improving clinical value using a design-based approach, and they combine principles of human factors design and scientific methods. One example of something that they've done that's been very positively received is an e-consult tool, which enables patients to have video chats with specialists in real time. The University of Pennsylvania uses designers to address certain key clinical issues. And one example of what they've done is to focus on late-day discharges. They developed a number of approaches for managing that, but one is to put in place an outpatient rehydration arrangement. And another one is to really change the way that they were doing things with scheduling. There are a number of pitfalls in this area. The first one really is failing to insulate the innovation groups from operational demands. If you take your innovation group and pull them back into operational issues, it will not go well. Healthcare as a whole dramatically underinvests in innovation. Big firms invest 10 to 20% of their revenues in this, and we couldn't find anyone in healthcare that comes close to that. Another is failing to set up methods to reinvest innovation profits. If you have dollars that come back in and you don't reinvest them, you won't set up a virtuous cycle. And finally, not taking a sufficiently long-term view is a common issue. So to wrap up, every organization is going to need to improve its efficiency. And for academic centers, you can both focus on improving value, but this can also be a revenue source. Innovation is really needed across the continuum, and that's especially true outside hospitals. And again, in the presentations today, we'll hear a good bit about that. Finally, identifying and spreading the successful innovations will be a key to success in driving improvement in value. Thank you.
Good morning. It's terrific to be here with you all today on such an important topic. I want to pick up where David left off in terms of strategies for assessing innovation. So you've heard about some of the good reasons and some of the activity going on around innovation in healthcare. What I can say is that, boy, we need that. We're going to talk, and we talk in our paper, with my paper with Beth McClellan, about care delivery innovations. That's changes in the way that care is delivered using some of the technologies, software innovations, process innovations, like David was describing in his talk. While there's clear evidence that there are many gaps in the quality of care, which these innovations could help address, and we list some on the slide, it turns out to be quite difficult to adopt many of these innovations to spread them in practice. This is often due to specific differences in practice circumstances, where how an innovation might be applied depends on local factors. It may depend on things like the financial and regulatory environment facing healthcare organizations. This is a little bit hard to read. It's a chart taken from a previous study that we did of the impact of the Medicare Accountable Care Organization program, the Medicare Shared Savings Program, where on the horizontal axis is performance of the Medicare ACOs in terms of these aggregate performance measures like diabetes control and patient experience with care and preventing undesirable or preventing avoidable complications. The vertical axis is performance relative to a spending benchmark. And all of these organizations were taking steps in one way or another to try to succeed in this new payment model to improve results and lower costs. Where you want to be in this chart is at the top right. About 1 in 4 organizations consistently made it up there, and for many of the others, even though they had many ideas that they were trying to implement to improve care, lower costs, or both, it didn't consistently happen. There may be some industries where better quality automatically is easy to implement and leads to lower costs, but healthcare is definitely not one of them. And that's one reason why not just the academic organizations, but all organizations, we think need to have a strategy around evaluating both which innovations to adopt and how to know whether they're working as intended or need to be modified. For this paper, we reviewed a lot of the literature. We reviewed our own experience and colleagues' experience with adopting innovations, and we tried to lay out a pathway forward for doing innovation. I want to emphasize that this is not something only for large organizations. So places like Partners Healthcare have David and his entire division to oversee the analytics and evaluation experience of innovations that the organization might adopt. Just because you are small, though, and don't have the capacity for a large-scale analytic capacity doesn't mean you can't do it. The graphics came out a little bit off on this slide, but there are a number of ways in which small organizations are learning more about what works in innovations that they undertake through things like partnering with insurers, with researchers, with companies whose job is who are trying to make a business case out of helping organizations innovate. There are ways to participate in registries or collaborations, learning collaboratives that can have some fairly quantitative support for evaluation. We divide our recommendations on approach to evaluation into 2 components: an assessment phase and an evaluation phase. The assessment phase involves taking a close look at the target population for the innovation and learning what you can about their baseline status, so you know what kind of performance improvements might be expected, and by comparison to what is known about particular innovations. Usually there's some published evidence or evidence that you can get from case studies or hearing from others about systems that have already adopted the innovation. It's possible to provide, to get a baseline assessment of just what kind of impact this innovation might have. It's also important to sketch out what the innovation is, especially if it's a significant one, so you have a clear understanding, as David mentioned earlier, of the resources and time likely to be involved in implementation. For the bigger innovations that do get implemented, if it's large enough, if it's significant enough, you're going to want to do a more extensive evaluation. In this approach, we think it's helpful to consider what an experiment would look like, even though it's often not possible to do a randomized experiment adopting an innovation for some patients but not others within an organization, and then tracking them on a randomized basis to really try to isolate the impact of the innovation. In fact, what's usually feasible is something that's more observational, where the different where the patients who receive the treatment are not necessarily randomized to one approach or another. And the paper goes through a number of alternatives for developing this kind of approach. We did want to particularly highlight this notion of a step wedge approach. Often within a larger organization, it's possible to start an innovation at certain sites, see what the early experience is, including some early assessment of results, modify the innovation for adoption at later sites to help refine and achieve the intended goals. This may not be possible to do on a randomized basis. We talk about an observational version, kind of a so-called differences in differences sort of assessment, but it is a good way to provide some ongoing evidence as to whether it's the innovation and not other factors like things that might have happened over time anyway, regression to the mean, external influences, or just differences between the patients who happen to get the innovation and those who don't, that could have accounted for results. We think it's possible to incorporate revisions in this process. A lot of people think of evaluations as starting at a point in time and having a very careful effort to hold the innovation constant. In reality, most organizations find ways to improve processes, to target it better, to refine what the innovation consists of over time, as long as you build in a kind of process that enables you to check in regularly, track some early indicators of whether the innovation is having its intended effect. It's still possible to learn a lot while recognizing the realities that innovations are often complex and do evolve. We also include in the paper a few comments about supporting better evidence on healthcare innovation. We're supposed to be moving into a learning healthcare system with all the developments this week around the challenges in providing affordable access to coverage. We really think this needs to happen soon. This should be a key part of strategies like learning more from real-world evidence about whether a drug or device works. There are ways to do this, we think. We describe practical approaches in the paper using help from ONC and incentives from CMS, tying into some of the payment reform incentives around quality improvement, some of the opportunities that exist for qualified registries to be used for both reporting on performance measures, to also be used for supporting better evidence on which innovations actually work, so that we can get to a much more rapid progress in implementation of innovations that actually do succeed in improving outcomes and lowering costs. Thank you all very much.
Good morning. I'm delighted to be here to present results from our paper that present a meta-analysis of patient-centered medical homes. I want to acknowledge my co-authors on the paper, who are evaluators of patient-centered medical home interventions from across the country, and I'm grateful for funding from the Commonwealth Fund for this work. So patient-centered medical homes, or PCMHs, are a form of delivery system innovation that aim to make primary care delivery more comprehensive, coordinated, and patient-centered. And I list here the joint principles of these initiatives, but want to just highlight that the goals of these initiatives are very high and broad, and they are to improve quality of care, reduce unnecessary spending and utilization of care, as well as to improve patient satisfaction and provider satisfaction. And there's been a real increase in the implementation of patient-centered medical homes over the last decade, and evaluations of these interventions have led to a very mixed set of evidence around their impacts on these goals. And there are really two competing hypotheses for why we see these mixed evidence. One is that there's true underlying variation in the impact of patient-centered medical homes across the practices in which they are implemented. But the other is a fact that relates to the medical homes themselves, which is that they're often implemented in small numbers of practices, and so the studies themselves are small and underpowered, in which case they're not able to detect an effect should it exist. And so the problem that this leaves us with is that payers and policymakers still are missing evidence that they can use to determine how to invest resources in primary care transformation and where to invest those resources. So to address this evidence gap, we conducted a meta-analysis of standardized findings from 11 major initiatives. And so there's a lot of detail on the methods in the paper, and I won't spend too much time on that here, but I just want to highlight that. So a meta-analysis, what it does is it's a systematic evaluation of effects across evaluations, and it does so in a way that accounts for the differences in certain characteristics of the estimates produced in the individual analyses, But there are two potential sources of variation in those estimates from the different PCMH studies. One is the true differences in the outcomes across the studies, but the other is variation in the estimates that results from choices that the researchers themselves made in terms of how they conducted their own evaluations. And so we wanted to eliminate that latter source of variation, and so we took a novel approach here in this meta-analysis where we collaborated with all of the evaluators who worked on the original studies to implement a standard method to both attribute patients to providers in the medical homes. We looked at this standard set of measures, and we also had all the evaluators implement a standard difference in difference method to produce a new set of estimates that went into our meta-analysis. And the measures that we chose to look at really come directly from the goals of the medical homes themselves. These are measures that we think are most likely to be affected by the practice transformation. And so the overarching result from the meta-analysis is that there's really substantial heterogeneity in the effect of medical homes across practices. So the meta-analysis gives us two sets of results. One is an average estimate of the effect of medical homes across the participating studies, and the other is a measure of heterogeneity in those estimates, which essentially tells us how much the difference in estimates across studies is due to true differences or likely to result from chance. And we find that across the majority of these measures that I showed you on the prior slide that we studied, all but 3, we find evidence of substantial heterogeneity across the evaluations. Then we looked at average effects and find no average effect across the participating evaluations in these utilization measures, primary care, emergency department use, and inpatient visits, or in 4 quality measures, in both the overall sample of patients in the medical home practices and in a subsample of higher morbidity patients. In the subsample of patients with higher morbidity, we find evidence of a reduction in spending of 4.2% from baseline. And I should note that all of the participating studies had data from both a pre-period and a post-period following medical home transformation, as well as relative to a comparison group. So we found a reduction in spending, but do find evidence of heterogeneity in this estimate. And then we find an increase in breast cancer screening among higher morbidity patients with no evidence of heterogeneity. And then among all patients, we find a reduction in specialty visits of 1.5% over baseline and an increase in cervical cancer screening of 1.2%, and there's no heterogeneity in these final 2 estimates either. So to sum up, I think that the evidence of heterogeneity really reinforced this idea already in the literature that patients that are medical homes are not like a pill that we can give to practices and then get a certain outcome, but rather there's real differences in how the transformation is both implemented and then emphasized over time that has important consequences for outcomes. And so you can imagine a medical home that emphasizes care coordination might have different outcomes on measures of utilization than one that emphasizes access. We do find evidence of a reduction in spending among medical home practices for patients with higher morbidity, but the fact that there's heterogeneity in this finding suggests real differences across practices in this finding, and that there are important differences in context and design that are related to achieving this outcome. And so that leads us all to this final point, which is that I think we're at a point where understanding the differences between medical home interventions is going to be really important going forward. What is it about certain medical homes, the context, the way in which it's implemented that make a difference in leading to the achieving goals of reductions in unwarranted utilization and improvements in quality versus the context where we're not seeing those results. Thanks.
Thank you. I'm going to talk about the impact of healthcare delivery system innovations on total cost of care. And I'd like to thank the contributions of my colleagues at RTI and at CMMI for their help on this. A lot of what we know about delivery system innovations is based on just one or two case studies or very limited samples of actual innovations. So what we tried to do in this study was to take a much broader look at a number of different innovations. And we were able to get access through our project to a sample of 43 different awardees that received awards. They received grants during round one of CMMI's Healthcare Innovation Awards. So these were all ambulatory care programs that we focused on. They're all doing some form of primary care innovation. The effects of any particular, of each of these awardees was estimated separately by a set of evaluators. So we actually have 43 different estimates of effect. Those effects were determined by contrast between the awardee performance and a comparison group of similar Medicare and Medicaid beneficiaries. We focused on total cost of care as our outcome after 2 years that these programs had been in operation. And I want to stress that the outcome here is not the actual expenditure in terms of total costs of care. What we're looking at is the impact or the effect that was estimated in each study for these outcomes. So the way that these were estimated, if there's a negative effect, that indicates that there is cost savings that was determined for this particular program. And if the effect was positive, that indicates that that's an unfavorable outcome because it indicates that there are excess costs for the awardee compared to the comparison. And then we looked at the effects of a number of different features on these outcomes using a technique called meta-regression. Here's what we found in terms of the system delivery innovations themselves. We found 5 different types of innovations that were used by these programs. The most common by far was health information technology. I don't know if you can read this, but that's the blue bar to the far left. And then following that, all of the other innovations that we coded, the different types, were below 50%. And second here is community health workers. Then we have medical homes. And then integrated behavioral health care. And then finally at the end there we have telemedicine, but there were comparatively few telemedicine interventions in the data that we looked at. About half of these programs had combinations of these 5 different service delivery types. So there's actually a lot of configurations, and it's pretty clear that these awardees are not just using one kind of innovation, one type of service delivery, and focusing only on that. So there's a lot of mixing and matching that goes on with these programs. This shows the regression results that we got from our meta-regression analyses. And I'm not sure if people can read this either, but the way that this is set up, we're showing actual regression coefficient effects. There's a vertical bar in the middle of this, which is the $0 outcome. So that indicates no savings at that particular point. So any effect that you see to the left-hand side is an indication that there was some savings associated with this particular feature. Anything to the right-hand side of that vertical bar indicates that there were excess costs, again, compared to the comparison group. So what this is showing is that 4 different types of service delivery are actually having some favorable impact on total cost of care, the total cost of care effect. So the top 4 here are health intervention, health information technology, HIT, community health workers is second, and medical homes and behavioral health also have both effects that are tending toward the favorable side. So there's cost savings. Telemedicine, on the other hand, the effect is on the positive side. That indicates that those programs are costing more than the comparisons. Although, again, there's really very few telemedicine programs that we had in our sample. And then we have a couple of other characteristics that we've included in here. One fairly common finding is that patients who have chronic diseases, who tend to be sicker to begin with, many times the cost savings are greater for those patients. And we had an indicator of people who were clinically fragile, and that also, in this case, is consistent with the literature and showing there's a potential savings effect here. A couple of other things that we've got included here. In previous work, we found that whether or not the awardee was a for-profit group or if they were working with a new program, one that they didn't have any experience with before, they tended to have non-zero effects. However, in this particular analysis, you can see that those effects are pushed much closer to zero. So whatever impact those characteristics were having tends to be explained in part by the type of service delivery innovation. One other thing that you'll notice about this is that technically none of these effects are statistically significant, and these are 95% confidence intervals. So if you're concerned about statistical significance, some of these effects are marginal, but others are not. Most of them are not. So to summarize, we found that about half of the awardees implemented multiple types of delivery innovations. So clearly they are not focusing just on one type of delivery system. They're mixing and matching, and these configurations may be important things to look at. We found 4 different delivery types that were associated with potential savings. Those, again, were HIT, community health workers, medical homes, and the integrated behavioral health innovations. And then finally, the precision of the estimated effects that I showed in the regression summary, we saw that they weren't statistically significant. That's largely a function, we think, of what's still a limited number of programs that we could look at. And we know that by increasing the number of programs by anywhere from adding 8 to 10 more will result in improved precision. It'll bring those effect estimates down to about $75, which is pretty impressive. Those would be rates per quarter per beneficiary. So that's a reasonably precise estimate with this approach. Thank you very much.
I'm going to ask a couple of questions and then get ready for those of you here to join in. David, I want to start with you. You mentioned, you used mushrooms as the metaphor for these innovation centers springing up. And I just wonder if you could elaborate a little bit on your impression of why. At a systems level, it's clear that we need to innovate, but I'm trying to think of at a individual academic medical centers' decision-making process. They have to not just feel that the world wants innovation, but that they need to innovate. And I wondered if you could just tease that thought out a little bit more.
Sure. I think most academic centers do feel the imperative to do that. Many are in a difficult situation right now because we still have a reasonable amount of fee-for-service, and there are mixed incentives, and investing in innovation is the kind of thing that you can do to prepare for what people expect to be the new world. So I think that's part of why it seems so attractive. And certainly the academic centers that are just focusing on generating revenue from the market, there's a very clear incentive right now.
Thank you. Mark, one of the things you discuss in the paper is the evidentiary needs of policymakers relative to evidentiary needs of people out there doing things and having a potentially different timeline. I just wondered, again, if you could sort of expand on that and how that ties into some of the methodological issues you mentioned in your presentation.
Sure. I think the point that we wanted to emphasize is if you look around the country, there are all kinds of innovations taking place in healthcare organizations. And you heard from this panel the specific features of innovation and how it's adapted by a particular organization, what its consequences are, do seem to vary. I think that's why there's so much attention to things like exchanging ideas from case studies among organizations that are trying to achieve goals like increase market share, increase value, or others. One of the obstacles to reaching more definitive evidence is that each of these organizations is doing things in their own way, often with very limited power and very limited capacity alone to do a meaningful evaluation, even for improving their own performance, leading to a lot of this uncertainty and lack of confidence about what organizations can do to achieve all of these improvements in care that the research literature would suggest is possible. Our policy conclusions were really focused on how to address that. Some of it's pretty simple, like trying to get more consistent data standards in place, even though people may be using different EHRs. It should be possible using API tools, the new FHIR standards, and so forth for organizations to use more consistent measures to review their own experience. Some of the efforts that HHS is undertaking now and the implementation of MACRA around steps like encouraging consistent use of so-called qualified registries or potentially encouraging other quality improvement activities like small organizations sharing data as part of and analytics as part of a learning collaborative, all could help close that gap. But I think there's really a tremendous gap right now between all of the innovation going on around the country and what we're actually learning definitively about it. And our recommendations are really about doing something to close a bit of that gap.
That's a perfect segue to the question. I realize, Anna and Kevin, you had very different papers, but there's something they both make me think about, which is when you're trying to understand an overall approach, it's great when all the results line up and you say it worked or it didn't. But both of you have examples where the answer is it depends. And I'm trying to figure out, as a policy journal, which we are, how to help the policy community understand an it depends kind of answer. Partly, I'm interested in your take on your relative confidence. If everything lines up, you can say, wow, we've done this a bunch of times in a bunch of different places, and this seems to be what happens. But the more you start subdividing out, the less the fewer sites or the smaller the n, whatever the approaches are, you have on those. So how do we give the policy community confidence that they can use the it depends answer to actually come up with the next action, as opposed to just more research is necessary, which is the last sentence of every paper we publish?
Yes, no, I know it's a challenge with the findings of our analysis because they really are, it depends. And I think that for the policymaker's perspective, I mean, what I take away is that there is an effect of patient-centered medical homes in some circumstances. And so it's not that there's no average effect or no effect, but that there are instances where we've seen success. And so what that says to me is that continued investment in this innovation is going to be important, and trying to do it in a more systematic way might be a good strategy to try to get better return on our investment.
Great, thank you. Kevin?
And I agree with that. I mean, I think you're always going to have an answer that is, it depends to some degree. What actually you've seen between both Anna's study and the one that we did is that there does seem to be something favorable about medical homes, which has been kind of a controversial issue for quite some time. But in terms of, I think the policy approach has to really be influenced by the kinds of results that we're getting. And I think the only way that you can really get that kind of information is by doing the kinds of meta-analyses and meta-regression that we've presented here. We need more studies, I think, to do that. We need better coding of what actually a service delivery type is, which is one thing that we kind of wrestled with, and we came up with 5 types. But clearly there's a lot more that can be done, I think, in that regard. And then otherwise, we just need studies, I think, that are a little bit better designed to try to get at these answers, and we need to be continuing to be experimenting.
Great. We have a little time for you all with questions you might have about delivery, and we have microphones, so we want to make sure that you have a microphone when you ask a question. I'll have Mike here kick us off. Identify yourself, although you'll be identified momentarily.
I'm Mike Chernew. I have a question to follow up on the one that you just asked about the medical homes. So in all of the situations, did each of the organizations have the freedom to design whatever features they wanted? So they were just picking the setup that they thought worked for their environment. And if so, is part of the conclusion that policymakers should not be prescriptive, but allow organizations the flexibility to see what they think might work in their setting?
Right, so all of the participating PCMH evaluations were natural experiments. So they were medical homes that were implemented in certain environments, and yes, they were developed sort of with that particular environment in mind, and we restricted to include only adults, so we to try to have some homogeneity across the populations included in the practices. But I think that you do raise a really important point, which is that often it is, that sort of internal institutional knowledge that can be really important to designing an effective intervention. That being said, I think that one of the findings that jumps out at me from our paper is that the result on spending was observed among higher morbidity patients. And so perhaps this is a signal that focusing on subsets of patients as opposed to an overall patient population makes more sense. And so that might be a place where, we might want to be a little bit more thoughtful in advance about how to implement.
Yeah, I think it would be tough to be very prescriptive. And certainly in the projects that we have looked at, the individual awardees had a lot of leeway in how they designed their programs. So, I'm sure in the medical homes that we looked at, there were a lot of variation in terms of how that was implemented. I know in particular that, the biggest group that we saw was the Health Information Technology group. But HIT can mean many different things. And that we haven't really tried, we haven't teased it out yet. But, sometimes HIT is used to, it's really directly related to patient care in terms of appointments and medications and progress and things like that. Sometimes HIT is just it's basically for population health. It's for administrative and record keeping. So I'm sure we have that kind of variation, and really I think in any of these programs, the sites, the awardees are really going to have to be developing the programs that they think are best. And then it remains for us to figure out, to tease out what's actually working out of that particular combination.
Back here.
Hi there. Actually, I think you just answered
Can you identify yourself first?
Sure. Hi, my name's Arun Natarajan. I'm with the Office of the National Coordinator for Health IT. I was actually going to ask you if you'd been able to tease out the health IT component of those programs, and if there were any specific health information technology applications or components that you were finding having better outcomes or if you'd been able to do a deeper dive on what health IT meant. But I think you just answered that.
Yeah, I think I did. It is, but there is a big effect for HIT. So if it's really a mixture of different kinds of HIT, and if it's really the personal health component that is having a bigger impact, that impact must be fairly large. But otherwise, I mean, we're aware of the fact that a lot of the awardees were using some form of HIT, and we just have not at this point tried to codify exactly what those types are, what impacts they had.
We had two folks up here, and then we'll see how we are on time. But wait for the microphone, please.
Hi, I'm George Greenberg, and I retired now, but I worked for 37 years in ASPE at HHS, so I've done this for a while. And my question really is, most of the suggestions are, as my understanding, most of these demonstrations, at least the CMMI demonstrations, were voluntary. And so most of the suggestions now are parsing that data, chopping it finer. I'm just wondering to what extent are demonstrations that are voluntary that have to have laxer standards for cost savings in order to attract participation, and the people who will participate think that they're the ones who can get the most savings, partly because they have the most problems. Whether we're looking at a first generation of subjects, so to speak, in the database, and what we really need is more policy that says there will be mandatory participation of all people with incentives that are both on the upside and the downside. And maybe we'll learn more from that kind of change and participation than parsing the data more finely. I just like a reaction.
Yeah, so question, I mean, and I'll throw this out to all of you, how do we take the results of voluntary interventions and think about them in the context of where they might be mandatory? Who wants to grab this question?
I'll start. I think that what I take away from all this is that it's important for policymakers to set the goalposts in the right place, and if you do that, people will figure out how to get there. It's notable that the place that we've had the biggest intervention is health IT. Wasn't mandatory, but it did have upsides and downsides, and we've had a sea change on the health IT front. We went from levels of adoption in the 10 to 20% range to over 80%, and now it's close to 98% in hospitals. So that is the kind of thing that can really change what people do.
Just to add that there are ways in evaluation methods to account for the fact that, as best you can, for the fact that this was not a random set of organizations that chose to participate. And I think several of the papers all the papers tried to do a careful job of describing, comparison populations that were reasonably well matched and difference methods and the like. In terms of more bold and mandatory experiments, that would probably lead to some more significant effects. At least cover a whole population more clearly and maybe more dramatic effects on practice. It's tough to do in practice, though, right? If you look at the results, even from these voluntary studies, they're pretty heterogeneous. Organizations have to adapt these big policy-level interventions like medical homes or a payment reform to their own specific circumstances, and it's just really hard for each individual organization to confidently go in and say and think that they're actually going to do better, know what they need to do to succeed, and learn whether what they're doing is actually succeeding. So you get these kind of small aggregate effects with very mixed results across different individual organizations. I think that's why we had such a push in our paper for ways to make it easier for organizations to learn from their own experience and to share those experiences across multiple organizations, not just to figure out what the size of the policy effect is, but also to help organizations know how to innovate more efficiently and how to be more confident that the steps they're taking are actually going to work. I think that's lack of confidence is why you don't see bigger experiments.
So we have one last question here, and then we're going to move to the next panel. Keep on going. Up, two more rows up.
Thanks. Hi, I'm Carolyn Robbins from HRSA, and my question is for Kevin Smith. So I think the research you're doing is really important to think about what's working, but I wonder if the definition of what's working is too narrow. So I'm interested in telemedicine, and so your research showed that it's not working, right? But telemedicine clinics are expensive to start up, but over the long term, they're not that expensive to run. And they're expanding service to people who wouldn't maybe be getting care in the first place. And so that's going to be more expensive as well. But in the long run, it's going to be, affected because you're going to be controlling chronic conditions and things like that. That would be expensive, over the coming years.
I think we have to take the telemedicine effects with a big grain of salt. Because as I pointed out, there were only, I think, 4 programs that involved telemedicine that were in our awardees. And only one of them was telemedicine only. So it means that telemedicine is getting mixed with some of these other delivery types. So I think that it's going to take a while before we really have a very refined telemedicine effect. And you could see how imprecise that estimate was. So, again, more data, more information about programs that actually use some form of telemedicine would be helpful for that. So don't get too discouraged yet.
And there are 2 papers in the issue that focus on particular interventions. And so I think that is maybe a good place to end this, which is we started with a higher level panel about context and some meta-analyses, and that is really important. What it often leaves is the question of what element, what place, what setting, and we have a bunch of papers that are much more focused on specific places, and you need some combination of the 2. You want the big picture, and you also want the more focused. So please join me in thanking our first panel for getting this started. We're going to move to our next panel, which is focused on commercial insurance and benefit design issues. I've got 5 people who we have to squeeze in up here, but we're going to move directly to their presentations. I'll introduce them as they come up. As I mentioned at the outset, it's hard to group these papers because there's so many dimensions along which they vary, but these are all papers that examine various elements of commercial insurance and benefit design. We for the purposes of the flow of the agenda, we organized by payer, which, as I note, is somewhat arbitrary, but I think it gives a sense. Many people are familiar with the portfolio of innovations at CMMI, particularly the Medicare side of those, but there is, as has been noted, a great deal of innovation going on across sectors. So in this panel, you'll hear from Michael Chernew, Leonard Schaefer, Professor of Healthcare Policy, Director of the Healthcare Markets and Regulation Lab at the Department of Healthcare Policy at Harvard Medical School, former Vice Chair of MedPAC, among other things. Dori Cross, doctoral candidate in the Department of Health Management and Policy at the University of Michigan School of Public Health. Hear from Scott Ashwood, Associate Policy Researcher at the RAND Corporation. Mary Reed, a research scientist at the Kaiser Permanente Northern California Division of Research, and Chris Whaley, Associate Policy Researcher at the RAND Corporation, Assistant Adjunct Professor at the University of California, Berkeley. I will turn it over first to Mike. There's your clicker.
So I am thrilled to be here. There's so much to say about all of these papers in the issue, and I think the momentum to move the system forward is really encouraging. I'm going to just present a little bit of results and some broad context to a study that we did that shows in the issue. It's an evaluation of Care First's TCCI program, which is a medical home program with strong financial incentives. And I would like to give particular thanks not only to a ton of co-authors that you'll see, also to Care First. And it really, I think it speaks tons for the organization that they were not only willing to be innovative, but they were willing to actually support financially the evaluation of their innovation. And they've been tremendous, tremendous partners. So a few basic landscaping points. The first one, which I think everyone understands, is there's Excuse me. There's a lot of concern that fee-for-service contributes to high cost and fragmentation of care in the U.S., and there's a ton of momentum around finding alternative payment models to support delivery system transformation. In these models, by and large, the delivery systems end up being accountable for the fiscal and the clinical outcomes associated with care, often, in particular in this case, on a whole patient level, sometimes just for an episode of care. But that's a broad trend of where we're going. The challenge is that the design of any of these programs has to suit their environment. So in the spirit of what Alan and Anna and Kevin were just talking about, even if I were to show you something that was tremendously good in one place, that does not mean you could go to another place and do exactly that same thing. The environment matters. It's not just the program features, but the context and everything matters. You have to design for your place. I'm about to talk about some numbers. Actually, I'm just going to show you a graph. I'm not going to talk about any numbers, so that was relaxing. But in any case, the key point is there's some basic semantics that I want to emphasize, and they should be straightforward, but unfortunately they're not. So, in any shared savings type program, the providers share the savings. Who knew? But that's the way it works. What that means is the gross savings will be bigger than the net savings because some of the gross savings will be shared. That's just semantics. If you don't allow any sharing of the savings, there will not be any savings that you could share. It is easy after the savings have been generated to say, I don't want to share, but understand the connection. That's just a semantic point. And it matters a lot, not just for how the programs work, but for actually the results. So the Total Care and Cost Improvement Program that CARE first launched was launched in 2011. It's a PCMH program with financial incentives. They're upside incentives. It's designed specifically for the local program environment in ways that I won't go into all the detail. It was really very well and carefully done. But there's some added fees for primary care physicians. There have upside risk based on the total cost of care for the entire population. There's a bunch of other features. There's a strong aspect of data support in there. They hired a bunch of care coordinators that were providing care plans for the sickest patients, recognizing the point that was made in the other program that often the savings opportunities are to reduce spending amongst the people that spend a lot of money. And so that was basically how the program was set up. It grew rapidly. Thank you, Alan. This is a gentleman. So it grew rapidly, and there was a lot of physicians. And our basic evaluation, I won't go through the design, was to compare people who, in 2011, their doctors joined. It's not that they picked to join. Their doctors picked to join to people whose doctors picked not to join. So you have to worry a lot about the selection of people into these programs. And dealing with selection is the type of thing that makes you choke and stay up at night. In any case, so this is the result. I'm waiting for the gasp. So what you see is there was not a big total savings. This is net after the bonuses, and so they were paying about 2% or so bonuses. So the fact that you don't see a big savings total is because any savings got shared in the bonuses. So our result would be consistent without a 2% savings. And if you looked at, say, the ACO model savings, that's basically what you would get. There's a bunch of things in our design that actually make the research design we did relatively conservative. So there's a lot of people, I've seen folks say, Shisha said, people have expected 30% savings to just melt away from the system when you put in a new savings model, which is wonderfully happy and cheery. No one has found 30% spending just drop away. You find small parts of progress where you can find progress. And because the way that the TCCI program worked is they put their savings in as a bump up to the actual fees and fee for service that were going on. And so they fit into our model where other programs like the Alternative Quality Contract in Massachusetts, they paid their bonuses separately. So it's sort of clear where the savings was and how the sharing played out. So my basic summary is, Overall, the program was budget neutral because the savings got shared. You could debate how much savings got shared or how it got set up, how you work out that part of the details matters. It is likely the quality improved. I can't prove to you the quality improved, but they were doing a lot of things that typically are associated with better quality, writing care plans, finding high-cost patients, doing a bunch of things like that. These sort of small single-digit results in savings before the bonuses is consistent with what a lot of other programs had. And I think most importantly, there's sort of continued improvement needed. And there's a lot of stuff going on in Care First to continue to work through the program. So sort of in the spirit of what Mark said and others, this is a process of going forward. This notion that there's some pill that you could take and now all of a sudden we're going to save 30% and let's move on to some other, education topic or some other, is just not the way this is going to work. There's a lot of people putting a lot of effort into making these changes, and it's going to require a lot of patience for success. So don't be frustrated one way or another. If you can improve quality that's budget neutral, that's a win. If you can save a few percent and improve quality, that's a win. And I think that's the basic bar that we have to hold ourselves to, in part because we don't have another alternative. So whatever you think about this, you can't compare it to who knows. You have to pick, well, what else would you rather do? And we could have a broader debate. In fact, you will see there'll be a VBID talk in a little bit about sort of other alternatives. But understand all these things have to be compared against each other, and none of them are huge fiscal savings. Most of them save a bit and improve care a bit, and then they just keep working. So I hope that's uplifting. For an economist, that's a really uplifting statement. But in any case, thank you.
There's more.
Oh, those are methods. If any of you ask me about methods, now they won't.
Okay. Good morning. I'm really happy to be here today to have the opportunity to speak with you all about some work that my co-authors and I are doing with support by the Commonwealth Fund. This work is really motivated by the need to better understand what's working in terms of caring for high-need patient populations, and particularly how can we structure healthcare services to deliver better value care for this population. So when I am talking about complex high-needs patients, the definition we're using is 2 or more chronic mental, physical, behavioral health conditions. These are patients that as we all know, account for a lot of healthcare spending, high utilization. They often experience lower quality, according to commonly used metrics, compared to healthier patients. And they have a lot of complex and distinct healthcare needs, so intensive care management, need for social support services, things like that. Things that can really challenge healthcare providers across the continuum. And so what we were looking at is, there's a lot of policy focus on this, providers, payers, everyone's kind of interested in how we can drive better value for this population. And so as we're looking at the constantly changing healthcare landscape, can we identify in terms of the primary care setting, are there particular practices that are doing a better job caring for this population? Are there characteristics of primary care practices that we can identify and say, you know what, this might give them an edge in terms of caring for this population? And so we decided to focus on 2 dimensions of what we're calling practice scale. So the first thing that we are looking at is what proportion of your patient panel in a primary care practice meets this high needs definition. And you can make arguments on either end. So if you have a lot of these patients, it could overwhelm your practice. You don't have the time, the resources, the staffing to give these patients what they really need. On the other hand, if you have too few of these patients, you might not have the critical mass that's really needed to invest in the specialized staffing or the resources that you need to meet these distinct care needs. When we look at practice size, there's been a lot of research on, are small practices better or large practices better in terms of performance on commonly used measures. And again, we can argue in either direction. So larger practices have more complex staffing structures. They have more capital and resources to invest in care pathways for high needs patients. However, there's also some research that says, small practices really have a comparative advantage in terms of developing patient-provider relationships and operating at a smaller scale that makes them more flexible and adaptable to organizational changes. And so what we wanted to do was look in population 1,300 primary care practices across the state of Michigan, multiple years of patient data provided from Blue Cross Blue Shield of Michigan. And we wanted to look at performance on a range of measures. So we have spending measures, we have utilization measures, we also had some composite quality measures, and trying to understand what is the relationship, what is the association between these two measures of practice scale and performance. And so I'm just going to give you a little flavor of the range of findings we found. We looked at a lot of different things. But I'm going to present our results that relate to the proportion of high-need patients on a panel, so that first dimension of practice scale I was talking about. So when we think about patients and practices that had a very minimal proportion of high-needs patients, so fewer than 2%, that's our reference group here. If we look instead at practices that serve a higher proportion, so moderate being 2 to 10% high-needs patients, substantial being greater than 10% of high-needs patients. And we see lower spending across the board for patients in these practices that treat a more substantial proportion of high-needs patients relative to the patients in practices with very few of these patients. So on the far left is total costs, and you can see for moderate practices, average total spending is 12% lower, and for patients in substantial practices, we see up to 40% lower. Similarly, when we look at utilization, these are odds of incurring an inpatient visit in a year, odds of an ED visit, odds of 30 or 90-day readmissions. And again, we see that there are significantly lower odds of any of these events occurring for patients who are being seen in practices that have a greater proportion of high-needs patients. Not on the slide, I told you we also looked at quality. So we had a 21 composite measure of quality used by Blue Cross Blue Shield that's looking at a lot of process measures, a lot of preventive health measures. And despite this positive evidence on spending and utilization, we do see that the practices with a higher proportion of the high needs patients, tongue twister, has performed slightly worse on that quality measure. And I'm going to talk about that again in just a moment. So when we think about what the key takeaways are in terms of our proportion of high needs patients, what we saw is that lower spending in practices that have more of these patients, lower utilization, not necessarily lower quality. And I'm happy to talk more about this, but we've thought a lot, if they're preventing ED visits, they're preventing 30-day readmissions, what's responsible for this worse performance on quality? And we talk a little bit in our paper about how these measures were developed and whether or not they're the right quality measures for thinking about a high needs patient population. If you have a really complex patient, you're trying to deal with a lot of pretty acute healthcare needs, you might forgo the mammogram, you might forgo certain screenings that would be a ding on your quality measures because you're focused on keeping that patient out of the hospital. And so should we be using those same measures that we're using for healthier patients also on these really complex patients? I did not have a chance to talk about our practice size findings. We find some evidence that smaller practices outperform larger practices. However, we saw reductions in spending, though not necessarily utilization. And so again, I'm happy to talk a little bit more about that. But in terms of policy implications, there's a lot of opportunity to experiment amongst policymakers, amongst payers, in sites of care that really specialize in this complex patient population. There seems to be some evidence of learning by doing, that as practices have more of these patients, they make the investment, they're really specializing in the care needs of this population. And so, we're not the first to think about this. There's ambulatory ICUs, there's step-down clinics. There are a lot of opportunities to try to concentrate these patients and care for them have them cared for by providers that have really specialized in the needs of this population. Thank you very much.
Good morning. I'll talk to you about our study of direct-to-consumer telehealth. I'd like to start by thanking my colleagues. Direct-to-consumer telehealth companies provide round-the-clock access to physicians. So I wake up in the morning, I have a sore throat, I can pick up the phone and talk to a doctor. I don't have to make an appointment, I don't even have to leave my home. So this raises a couple of interesting possibilities as far as spending and utilization are concerned. On the one hand, if when I woke up with a sore throat, I would have made an appointment and gone to my doctor, then there's an opportunity for telehealth to replace that visit. And because these visits are less expensive than visits to physicians and especially to emergency departments, there's an opportunity to save money. On the other hand, if when I woke up with a sore throat, I would have just taken a cold pill, then now I have increased spending because my insurance company has to pay for the visit to the telehealth visitor. So my colleagues and I were interested in how do people actually respond to this new innovation in delivery. And we had access to a commercial claims database for about 300,000 enrollees in California that started offering direct-to-consumer telehealth to their enrollees in 2013. So I'll summarize our findings. First of all, we looked at episodes of care. So we're focusing on acute respiratory illness in our study because that's the most common type of reason people visited DTC telehealth in our sample. And we're going to look at an entire episode of care, which includes not just the visit itself, which we know is less expensive on average, but also follow-up care, prescriptions, imaging, and testing. All of these things could vary by the setting in which you get care. And what we find is that even on an episode of care basis, direct-to-consumer telehealth is less expensive than physician offices and especially emergency department visits. And in the paper, we break this down by type of spending. So we look at follow-up evaluation and management, we look at prescriptions, we look at imaging and testing, and across the board, telehealth is less expensive on average. Our main interest, however, for this study was this question of replacement versus new use. And this slide summarizes our results. Let me break it down a little bit for you. So our approach to answering this question was to define two cohorts. We have a cohort of telehealth users, and we have a cohort of matched controls, who are people who look just like the telehealth users on things like demographics and health status, who do not visit telehealth, but visit either a physician office or an emergency room for acute respiratory illness. So these are our two cohorts, and we're going to compare changes in their utilization over time. So on the left, we have visits for telehealth. At the beginning of our study period, these are 0. Telehealth isn't available. For our telehealth cohort, at the end of our study period, there are an average of 85 visits per 100 for acute respiratory illness. That's the red line. The gray line on the bottom is the non-telehealth cohort, and they have 0 throughout because they're non-telehealth users. On the right, we've combined physician office and emergency department visits together, and we see that on average there's an increase of 27 visits per 100 to these providers for our matched controls. So they go from an average of 60 to 87, so that's an increase of 27. The telehealth cohort, however, only increases by 17 in the same time period. So if we've done this right, we would expect the same increase in both populations in absence of telehealth. So this decrease, this relative decrease of 10, represents substitution. We're saying that on average, 10 visits are replaced by going to telehealth. And if there were only 10 telehealth visits, then we would have complete replacement. So all 10 visits would just be telehealth visits. However, we see that there are in fact 85 visits per 100 in our telehealth cohort. So the 10 represents only 12% of the total direct-to-consumer telehealth visits in our cohort. So only 12% replacement, meaning 88% new use. I don't present the spending findings here, but we then plug in some spending numbers that were available to us in the claims. And on average, while there are some savings from replacement, the net impact on spending is an increase of about $45 per telehealth user. So most visits are new use, and that leads to an increase in spending. So there are a few implications. The one is that this finding actually shouldn't be that surprising. You've given consumers a convenient alternative, and they responded. There's no guidance here in how to use this provider. They just say, look, you now have access to doctors around the clock, and people respond. That's not surprising. And in fact, it shouldn't be surprising that spending doesn't actually go down. So an implication here is that if you want to give your consumers access to a convenient alternative, they're going to use it, but you shouldn't expect to save money in this particular form of telemedicine, which is direct to consumer. So that means if you want to give your enrollees, your consumers, access to the benefits of around-the-clock access to doctors, you need to think creatively if you also want to try and save money. And we provide a couple of ideas for ways that might work. I'm sure you all can think of others, but a couple that we thought of are increased cost sharing for patients. So if you increase the out-of-pocket cost for that visit, the co-payment for that visit, that might make me think that if I woke up with just a sore throat, maybe I won't call the doctor. But if I have a sore throat and a fever, maybe then I would call my doctor. So I think a little bit more before I pick up the phone. And then there might be ways to target direct-to-consumer telehealth to high-cost populations, populations that you find are consistently going to the emergency department, for example, for these kinds of conditions. Maybe you can direct them in this direction. So that's our study. Thank you.
Great. Hi, I'm excited to share with you some findings today from a study that we did to look at a value-based insurance design around pharmacy benefits. So these are generally plans that create some clinical nuance in the way that the out-of-pocket costs for patients work. Rather than having a fixed cost, there are ways to vary that cost based on the clinical value of the treatments. So in this case, what we looked at was patients switching to a deductible plan, as American patients often are these days, to see if adding a value-based insurance design pharmacy benefit that actually offered free medications for the chronic conditions medications that they were taking for things like diabetes and hypertension and cholesterol controls, to see whether that affected the way that patients took their medications. So essentially our research questions were among patients, and this is a difference in differences design, among patients whose employers were switching them to a deductible plan, how does having a value-based insurance design pharmacy benefit, again offering these medications free out-of-pocket costs from day one in the year, affect their overall patient medication adherence compared with if they just switched to a deductible plan without this value-based design. The medication adherence is generally sort of a composite measure of the proportion of medications that patients are taking according to prescription, essentially. And then we were particularly interested in some subgroups. We were interested in those that started out with lower baseline adherence, so patients who are already not really taking their medications as often as they were prescribed. What happens to them when they switch to one of these plans? Previous research has found that patients with lower socioeconomic status, we use a composite measure of education and income, typically reduce their medication use more when costs go up. So we're curious what happens when those costs are sort of held down. And then we're also interested in patients with higher medication burden, patients who are taking more medications. How does it affect their medication taking behavior? So here's what we found. This is the figure from the paper. Essentially, this is the change in medication adherence after switching the deductible plan. So on the left is when everybody had no deductible, and on the right is when they all switched to a deductible. In the blue line, you see those who switched to a deductible plan but don't have a value-based insurance design, they decrease their adherence. Many of their out-of-pocket costs are essentially going up, and their medication taking behavior might decrease a little. Those with the value-based design there are in the orange line, and rather than decreasing, it looks like the value-based plan actually offsets the deductible impact, and we see a higher rate of adherence among those who switch to a deductible plan that has these free chronic conditions medications. And now this is the same plot, but again, among those non-adherent patients, patients who didn't appear to be. So the first one was the overall effect, and then this is among patients who didn't look like they were taking their medications very regularly to start with. In this case, we actually see a really reassuring thing, that the patients with the value-based insurance design are actually increasing the number of their medications they take when they're free. This is exciting across a backdrop where out-of-pocket costs are probably going up for the other types of care that they encounter. And here's where the story gets a little bit more complicated. In this figure, I'll show you the findings by socioeconomic status. Again, our hypothesis, we were hoping to see that potentially patients with lower socioeconomic status might benefit a little more. Actually, those with the lower socioeconomic status showed no difference at all whether or not they had a value-based insurance design added to their deductible plan versus not. They behaved the same. It appears that potentially the complexity of the plan maybe was overwhelming, or patients had difficulty navigating the value-based plan. And where we see most of the impact that I showed you from the first slide is actually in those patients with higher socioeconomic status. So there's kind of room for improvement here in the way that we reach out to patients to help them to navigate a relatively complicated insurance benefit plan. I don't have time to show you the findings for those with the higher complexity that I mentioned before, those that were taking more chronic conditions medications, but we actually see a little bit of a counterintuitive finding there too, where those who are taking more medications are less likely to adjust their behavior. It's those who are taking fewer medications, I think, who perceive the benefit. Things are a little bit clinically probably more simple for them, and they're able to navigate the plan accordingly. So overall, our findings are that the value-based insurance design looks like it offsets reductions in patient medication adherence associated with switching to a deductible plan. We're encouraged to see that it looks like it's particularly beneficial, and patients started out with lower medication adherence. So they were engaged by this sort of value-based nuance in their out-of-pocket costs. And then the thing that we need to do more with is patients with additional clinical complexity, like I mentioned before, or those with lower socioeconomic status actually appeared not to be taking advantage of some of the plan provisions and may need additional education or engagement. We're actually working on a project right now to try to do that. Thank you.
Great. I'm excited to talk about reference pricing and how it changes the choice architecture for consumers in healthcare. This is joint with Jamie Robinson and Tim Brown at UC Berkeley. And just to acknowledge our funders, so this is funded generously by the California Public Employees Retirement System, the Agency for Healthcare Research and Quality, the RWJF, and also the Laura and John Arnold Foundation. Our medical claims data that we use for this study are provided by the Healthcare Cost Institute, and the data contributors who provide data to HCCI, Aetna, Humana, and United Healthcare. So there have been many studies that have shown that there's a lot of price variation in healthcare. For many services, there's up to 10x variation in prices for what we think are common and shoppable services, and there hasn't been a clear link between price and quality. And so for these types of shoppable services, reference pricing programs are one potential solution to get consumers to shop for care and to go to low-price providers. And basically how reference pricing programs work is that the payer sets a reimbursement limit for each program. The patient's free to go over what they want, but if they go to a provider with a price above this reference price, then they pay the difference. And so for some services, this can be a pretty strong financial incentive to shop for care and to go to low-price providers. And so we think that reference pricing is one potential model to change the choice architecture of healthcare and to incentivize consumers to shop for providers and to go to low-price providers. In previous studies, Jamie, Tim, and I have examined reference pricing for a couple different employers, mainly CalPERS and Safeway, for a few specific inpatient surgery, outpatient surgery, and diagnostic procedures. So in particular, we've looked at knee and hip replacements, cataract surgery, colonoscopy, joint arthroscopy, and then also lab tests and advanced imaging services. These services in 2013 nationwide accounted for roughly $100.6 billion in spending among the commercially insured population. And our studies have demonstrated that among these services, reference pricing programs lead to fairly sizable reductions in spending. So our service-specific estimates range from a low of 10.5% for MRIs to a high of 32% for laboratory tests. And so what we do in this paper is ask what would happen if reference pricing programs were expanded more broadly beyond just the employers who have implemented them so far. And so to do this, we use data from the Healthcare Cost Institute and pair it with data from the CMS Office of the Actuary. And for each of the services that we identify as potential targets for reference pricing, we calculate the share of medical spending among the commercially insured population that service accounts for, and then also the total spending on that service. We then use our estimates from our previous studies as a baseline estimate of what might the effect of reference pricing be for that service. And so if we just look at the services for which reference pricing programs have already been implemented, here we're thinking of the exact same procedure codes for the services that I mentioned, we estimate that reference pricing, if expanded fully, would lead to about a $20 billion reduction in total medical spending, which is about 2.2% of spending for the commercially insured population. And I think one caveat here is that this is an estimate assuming that we'd get the same effect as we found in the previous studies, but then also assuming that the reference pricing was put in place for all of these services. And if we also then similarly think what would happen if reference pricing was expanded beyond just the services that have already been studied, here we estimate that a more expansive reference pricing program would lead to about a $75 billion reduction in spending among the commercially insured population, which is about 8.5% of total medical spending. And an additional point that we make in the paper is that expanded reference pricing programs are likely to exert pricing pressure on high-priced providers, especially for more common procedures. And while we think that there are pretty clear financial benefits of reference pricing programs, we also identify some conditions for successful implementation of reference pricing programs. So one, reference pricing is not appropriate for all services, and services should be shoppable services and services that we can identify as more commodity-type services. For these services, quality should be measurable, or these services should not have much of a quality dimension. And patients need to have accurate information about both price and quality. The patients in markets where reference pricing is applied need to have access to a sufficient volume of low-price providers who still have a high quality. And then also patients with special needs and conditions need to be exempted. So in all of our previous studies, patients with special clinical conditions were fully exempted from the program. And then finally, regulators may need to be accommodating to expanded reference pricing programs. Thank you.
I typically ask searing, probing, clarifying questions at this point, but I actually think the presentations were incredibly clear, and I would much rather have you all ask follow-up if there are things that weren't clear to you. I, of course, have the advantage of having read them before. But I do think I'd like to spend a few minutes before I open it up to the room. In the first panel, we had general, and there were a lot of questions about what the specific findings are underneath the general. Here we have specific, and there's a natural tendency, at least on my part, to want to move to the general. And somehow, if we do the two, maybe we can figure some things out. So I just want to tee up a couple of questions. Mike, I want to start you very directly and importantly described that in shared savings, some of the savings are shared, and that's your major finding. My question to you is, the payers, ultimately, you described a transaction between the insurers and the providers. Ultimately, it's the payers who are bearing the cost and who are seeing premiums go up and healthcare costs go up and are saying, when do we get a piece of this back? We've been plowing a lot of money into the system. You tell us it's inefficient. So when it becomes more efficient, shouldn't we be the beneficiaries? And yet, as you pointed out, if you want the providers to change their behavior, you have to share, for financial reasons, you have to share with them, or else there's no incentive for them. So can you just talk for a minute about sort of the ecosystem, adding the third party here, because you focused very much on the two, and I'd like to bring the payer in.
So first of all, I should say, I have the honor or misfortune of chairing the Harvard Benefits Committee, and we have this exact issue all the time because we want the money. In fact, it turns out one of the tenets of economics is everybody wants the money. The only thing I can say is I think that our focus needs to be on the healthcare system in 2020 or 2025, and the way that employers, payers get money out of the system is going to be through a transformed system and a slower rate of healthcare spending growth, as opposed to pulling money out right away. There's a number of specific things that occur. A good example would be in the Medicare ACO program when they're changing their benchmarks. This question comes up of how quickly can we get the benchmarks down, and should we take it away? If you do really well, do you take it away more quickly? My general view is do not take the money away so quickly. Do not set up a model where if you're very successful, you're going to see less payment down the road. Try and set a trajectory that you think is sustainable so that when we sit here in 2025, we're happy, even if that means you've gotten less money out of the system right away. Not because I don't think that the payers should get money out of the system quickly. I think they do. I just think if they don't create the incentives for the system to change, we'll end up where we've been, where it turns there's no money for anyone to get out.
Because we organize these by payer, each of the interventions is quite different, but I want to start, Dori, with you and ask the rest of you, and actually this applies, Mike, to yours as well. I want to talk for a moment about the role of the payer. Each of your papers focus on an intervention and analyzing the results of it. So, for example, Dori, when I look at your findings, you have sort of this hypothesis about what's happening inside the walls of the practice and whether different size and different ratios of high need affect what happens inside. But this is in the context of a payer, and you're looking at data from one payer that has made a major investment in medical homes and is interested in changing practice. So I wonder for you, and if each of you in your own papers could talk a little bit about how active or passive a role the payer played, not just in setting a payment policy, but in actually reaching into the world of care delivery to either, in your instance, support high need, to provide information about pricing, to educate users about the benefit designs. What's the role of the payer here in addition to just paying?
Yeah, so we were very fortunate. Blue Cross Blue Shield of Michigan was a really active partner in this and very interested in our findings. And, in addition to presenting the findings from this paper, there is a qualitative component to this project as well. We were interested, Commonwealth Fund was interested, Blue Cross Blue Shield of Michigan was interested in what's happening inside the black box. So actually talking to these practices and trying to understand, you're involved in pay for value, you're involved in patient-centered medical homes, but what are you doing and what feels the most impactful to you on the ground? How can we support you better in the implementation of these programs? And we looked at high-performing practices, we looked at non-improving practices, and tried to actually tease out what are those differentiating strategies that seem to be making an impactful difference in how care is being delivered overall and specifically for these high-need patients. And I think Blue Cross was paying particular attention to that when they're thinking about the structure of these programs. What are they measuring? What types of resources are they providing to physicians and to primary care practice staff to really try to target their investment in a way that's going to maximize value?
Great, thank you.
So in our case, I didn't mention this, but the employer was CalPERS that Chris also studied, and the claims provider was Blue Shield of California. And the decision, my understanding of how this process worked, was it was a combination of CalPERS, mostly driven by CalPERS, to want to provide a convenient alternative for getting access to doctors for their employees. And Blue Shield was their insurer and worked with them as well. So I think that CalPERS wanted, on the one hand, to provide greater access to care for their employees. There was this sense that as we went into this study, and one of my co-authors is from Blue Shield of California, so we mostly worked with them. There was a sense that there would also be savings. So that's what a lot of these providers tell people, is that they're going to save money, and they have some evidence to support that. But the evidence hadn't been looked at in the same way that we've gone about looking at it. And so I think that was their hope, was that they would get everything. They would get increased access for their employees so they could get to the doctor easier, and they would save money at the same time. And so that was the hope. And during the study, as we got our results and began talking to Blue Shield in particular, they began to change their mind, at least about the savings part. I mean, access to care, we find a lot of support for that, but not necessarily for savings.
Mary, you of course work for the payer, so I get to put you on the spot.
Not directly for. I mean, I guess in terms of whether the patients received any special education about these complex plans, they didn't. I think that's traditionally been sort of a shortcoming. As plans get more and more complicated, it's very difficult to navigate them, and there was not any special outreach compared to other types of insurance benefits. And I think that's one of the learnings we took from this study and are trying to do an outreach right now to see if we can help people to understand how to navigate the plan. I would say the other interesting nuance, like Scott said, is that the employer had to essentially choose to offer one of these sort of value-based insurance designs on top of their benefits. And I think that there's more to explore there in terms of which employers make those choices and why. My guess was it was to essentially protect access to these chronic conditions medications, and at least our study shows that it was effective in doing that.
And so for reference pricing programs to work, it really has to be a strong intervention by the payer, whether that be the employer or the insurer. And I think in addition, patients, as I mentioned towards the end of my presentation, patients really have to have good information about prices and have to have accurate information that allows them to shop. And I think both of those limitations, one, the enthusiastic employers and the innovative employers, and then also the current level of patient information about their benefit design and about different providers, has limited the expansion of reference pricing and other similar types of programs. And so if we're thinking about potentially expanding these types of innovative insurance benefit designs, then I think addressing both of those current limitations will be very important before we just kind of go ahead and change benefit design by itself.
And Mike, you commented a little on this in your presentation, but say a little more.
So CareFirst was very engaged with their practices. They paid a bunch of care coordinators. Those dollars actually were paid through the fee-for-service system, so we're actually in our spending numbers, which is commonly not true because they're typically paid outside. They encouraged writing of care plans for the high-risk people, which was very engaged. So they were quite engaged. We also had a qualitative component actually led by Rob Mechanic. It was a lift, quite frankly, to get the practices really engaged in a whole variety of ways. You can read more about that in the study. But the general takeaway that I would have is, and again, I feel like I'm mostly talking in tautologies, but if you want to save money, it's really useful to actually go after things that will save money, do less stuff. It is harder to save money by doing more stuff and hoping you'll save money on the back end through health. It is just, for the right populations, the right interventions, that might be possible. But broad population things, particularly in employed population, the easiest way to save money is actually to spend less money and not spend more money and hope later you'll spend less. It might be over time, good things happen. It's good to give people chronic care meds. I'm a huge supporter of the VBIT stuff and all of those things. But if you're only interested in money, you have to figure out where the waste is and actually try and design your program to go after that. And frankly, Care First was really designed on improving the care. And then it ended up, after all the spending on that, they were basically budget neutral after a bunch of other good things.
Okay, let's bring folks in, and again, microphones and.
Mike Miller, I'm a physician, a health policy person. I want to follow up on with Mike Chernew and what Alan's question. I've been following and a member for Care First for a long time, certainly since 2011 when they launched what they called their PCMH. And Mike, you mentioned that quality likely improved, but one of the criticisms of Care First program is they created this PCMH, but they didn't use anybody else's model, and it wasn't unclear how they defined what a medical home was going to be. And it really came down to they didn't seem to have any quality metrics, and as you said, it was all about saving money. My understanding is that each PCP received an average of about $25,000 increased revenue per year. And you said before, like ACOs, like the Medicare Shared Savings Program, in terms of bending the long-term cost curve, one of the things they had structured their program as is they had to meet a quality threshold before they could share any savings. So from a long-term public policy perspective, can you comment on how what Care First is doing, where it really seems to be around, as you said, you save money by doing less, but without any quality metrics, that is not, I won't use the word rationing except to reference it here, but say from a public policy perspective, how is patient-centric if there's either there's none or very opaque quality metrics, and as Alan referenced, the savings aren't going back to the payers or the patients?
So Care First actually had a wide number of quality metrics, and I think they would take issue. I would think they would argue that they were mostly about the quality and not as much about saving money. And I would think the design of their program, although there were some shared savings that you could get, was really around focusing on aspects of these care plans and hiring nurse coordinators and making sure that people with chronic conditions were getting more services in a variety of ways. So I think they put much more weight on the care improvement part than they did on the cost savings part by and large. The PCMH title is, it's not necessarily exactly the same PCMH as you might have seen in all the others, but as Anna pointed out, there's huge heterogeneity in how that is designed. So I think as they continue to work through what they're doing, they found that a program that was designed with a large quality component would need something, my opinion, not theirs, would likely need something in addition if you were going to get the fiscal savings out, because they did not start the program with let's save a ton of money and see what happens with quality. They started the program with a ton of quality measures and a ton of
I'm going to take this to the break because we've got a lot of other folks who want to get in. There's someone in the back. I'll take you here. We'll come up here.
Hi, Kim Zubarek with the American Academy of Nursing. With Scott, with your analysis on the cost saving, was there any consideration on not just the cost for the insurance and that, but actually the reduction in lost employee hours? So in other words, if an employee can go through telehealth, but they're not missing 3 hours of work in the morning or having to leave at 2 in the afternoon, was that factored in at all?
Yeah, that's a good question. We include in our paper, we did a sensitivity analysis that included time. So to answer your question, we didn't look at whether by using Teladoc, the employee was treated sooner and able to get back to work sooner. That's not something that we look at in our study, and that is a possibility for what's going on. Another way that we looked at time, however, was to look at potential time savings for the visit itself. So there are studies that have tracked how long it takes to do a physician office visit, and they break it down by travel time and waiting time and time with the physician. And so we use those numbers to try and estimate how much someone might save by using direct-to-consumer telehealth as opposed to going to the doctor's office. And again, those numbers aren't really solid. It's sort of a sensitivity analysis, but it's a similar result, which is that because now people are using telehealth instead of just taking cold medicine, they actually wind up spending more time on care in the year too, because now they actually are spending time on the phone talking to someone as opposed to just going into the bathroom and getting a cold pill.
So So I'm going to try to get as many in before our time is up as possible. There was some, we'll go to you, then I'll go to Josh, and I'll come up here, and we'll see how we do this.
Hi, I'm Nora Super.
Nora.
I'm with the National Association of Area Agencies on Aging, but my question is more as a member of Kaiser Permanente, and I used to work at Kaiser Permanente, so I consider myself a pretty educated consumer. But when you were speaking, Mary Reed, about the value-based insurance design, I realized, all of a sudden I wasn't paying anything for my prescriptions, and I had no idea why. And now you're explaining that that was part of this value-based insurance design, and as a patient, I had no clue why that was being done. And so it's not surprising to me at all that that it didn't affect SES people if they didn't even know that this had changed. So perhaps they didn't even know that their prescriptions were going to be free. So that seems to be a real deficiency in the design. If it wasn't, if they weren't informed that now their prescriptions were free and that their doctors could be telling them, we really want you to take these drugs, that could make a big difference, I think, in whether or not they would take them. And also, I think it relates to what you were saying about the telehealth project too, because again, as a Kaiser member, that's something that we really value, I think, is being able to just send an email to our doctor and ask a question. If we had to pay more too, or our employers saw, as the other questioner said, that you don't have to go in for a doctor's visit because you can just email your doctor. But I know my doctors complain that it's a huge time suck for them. So, I think some way to look at how that might be something that those of us who are more affluent could pay more for the convenience of that, and how to measure that, I think, for you researchers. And I don't know if you have.
So I guess I'm just going to take sort of ask the question of how important is it when we're experimenting with these things that everyone is in on it? Because in a lot of evaluation work, you want to avoid people knowing, and yet these are your enrollees. So how do we deal with that sort of the ethical issue, but also the effects analysis issue of how much enrollees and patients know they're in an experiment?
I mean, I would say for our study, at least, our goal was to take sort of the natural history of what people are able to do and understand in navigating their health insurance plan. So we made a special effort to make it opaque or to have special outreach. I think, like I said before, patients essentially, we all could go and look at our HR materials and understand exactly all the nuances in our insurance benefit design. I think few people do that. I'm sure the people in our study didn't all do that. And essentially, you approach a pharmacy or a visit with sort of a rule of thumb in mind about how much it might cost. And I think that these value-based plans might beg special outreach because they are more nuanced. And even when plans are sort of intelligently designed and thoughtfully designed, as they become more complicated, I think it does just sort of get trickier to navigate and might need extra outreach. I agree.
So I'm going to try to get two more in. Let's get the microphone to.
Hi, Josh Wiener, RTI International. This question's for Dori. So for the practices that had a very high percentage of high-risk patients, do you have any sense from your qualitative work or your quantitative work on how that came to be? Was that something that just happened to them, or was that something they sought out and wanted to be? Was it the consequence of their referral patterns? How do you get to be a high-risk practice?
It's a great question. So obviously there was no assignment we were not assigning patients to practices. We received this data from Blue Cross Blue Shield. These are patients that stayed with the same provider in the same practice for the 4-year time period of our study, and we took it as is. So we, categorized the practices based on these proportions, and we don't know the history of how a practice ended up in the pile with fewer than 2% high needs patients and how these practices ended up with greater than 10%. We also don't know, because this was we were looking at commercially insured Blue Cross Blue Shield patients, so we don't know what was the proportion of high needs patients in their Medicare populations. Did they see Medicaid patients, and how many of their Medicaid patients were high need? So, on the one hand, it was a real wealth of data that was handed to us, but on the other hand, there are a lot of limitations in what we can say and what we can interpret from our findings based on what we were given.
So let's take our last question here, and then we'll go to our break. Wait for the microphone.
Carpenter, Vice President of Strategy and Research for our local health system. I'll end with another question for Dori, which is, let me share a quick hypothesis and then a follow-up question. I think the quick hypothesis is, if you were to substitute medically complex patients with different types of surgical patients or other kinds of surgical activity at hospitals, you would find the same quality trends, that when you do the same kind of stuff with the same kind of people, you in fact get better at it. And I think it's an interesting almost assumption, I'll say a little bit of an almost arrogant assumption, that medically complex patients, anybody can do it or anyone can be successful compared to, say, complex surgical needs. And then the question for you is, you kind of gave a little bit of a bimodal cut on your data with the, hey, you were either in this bucket or that bucket. If you laid it all out and did the R squared, what would it look like? Sorry to end on a very nerd question, but I got it.
But it's 3 slices, not 2. So
it is 3 slices. So I can't cite an R squared for you, I'm sorry. We did try to slice and dice the data in a lot of different ways, because these groupings were conceptual more than anything. We looked at the distribution, and there weren't really clear cut points, so we said, at what proportion do you feel like there's kind of a tipping point? Greater than 10% felt like a lot to us, but just because we felt like that was a lot, we wanted to really cover our bases. So we also cut the data by quartiles. We looked at it as a continuous measure. But in terms of, being able to look at the paper, look at the results, and easily interpret what we're finding, we felt like these 3 categorical groupings made sense in terms of being able to interpret our findings, which is why we presented it that way as opposed to a continuous measure. Thank you.
Okay. We have 7 more really terrific papers, but we're going to give you a little break. Since you kind of grabbed a little one before this panel, I'm going to grab a little of it back. No more. We're going to keep this under 10 minutes, but please join me in thanking this terrific set of presentations. So our next 2 panels are focusing first on Medicaid and the safety net, and second on Medicare. As I noted at the outset, there's a good deal of attention being paid to innovations being funded and evaluated through the federal Centers on Medicare and Medicaid Innovation. The Medicaid topics being explored here are not directly out of CMMI. Some of the Medicare ones, actually I believe all of the Medicare ones are, but just because of different genesis doesn't make them any less important given the discussions going on about the future of Medicaid, particularly at the moment. You're going to hear first from John McConnell, health economist and director of the Center for Health Systems Effectiveness at Oregon Health and Sciences University. You'll hear from Heather Dahlen, a postdoctoral research fellow with the Medica Research Institute, and from Michael Barnett, assistant professor of health policy and management at the Harvard T.H. Chan School of Public Health and primary care physician at the Brigham and Women's Hospital in Boston. I'll turn it over first to John.
Well, thanks for the opportunity to present the results of our study. And thanks also to Alan and his team at Health Affairs for making this possible. I want to, this is a team effort, so I want to mention my colleagues on this paper and also note that we're grateful for the research support we received in the form of grants from the National Institute on Mental Health and the Silver Family Foundation. As many of you are probably aware, the Medicaid system is now the largest health insurer in the country. It covers 74 million people, or almost 1 out of every 4 Americans. It has a broad reach, covers about 40% of children, pays for about half of all births, and is a critical source of funding for low-income and vulnerable populations. Like all insurance programs, commercial, Medicare, it has not been immune to healthcare spending growth, and this has put particular pressure on state budgets. And to that end, you've seen a lot of states begin to experiment with ways to control costs, including the delivery system. And the state of Oregon has been at the forefront of some of these efforts. So in 2012, Oregon, with the help of a substantial investment from the Centers for Medicare and Medicaid Services, transformed its Medicaid program into 16 coordinated care organizations, or CCOs, which provided coverage for 90% of its Medicaid beneficiaries. CCOs can be seen as a type of Medicaid accountable care organization. They're locally governed. They're accountable for healthcare spending, access, and quality for a defined population. Put a lot of emphasis on primary care as a way of coordinating care and managing spending. But there are some differences from regular or more traditional standard Medicare ACOs that we may be more familiar with. First, CCOs accept full financial risk in the form of a global budget. In other words, they take a risk-adjusted per-person payment and then manage spending and care within that budget. Second, although we think of CCOs as a type of Medicaid ACO, they also have some similarities to Medicaid managed care organizations, or MCOs, in that there's an administrative layer there that takes payment from the state and then distributes that to providers. And third, CCOs encompass a broad set of services, and they're responsible not just for physical health, but for integrating mental health, addiction care, and oral health services. They have a lot of flexibility in how they can spend their funding, and so a lot of them have focused on upstream public health, on things like social determinants of health, in the hope that that could improve health for the population that they serve while also slowing healthcare spending. And when you put all of these things together, the global budgets, the fact that it's covering 90% of the Medicaid beneficiaries in the state, the scope of services, this has led some observers to call CCOs ACOs on steroids. So our intent here is to understand the impact of this transition into CCOs on utilization and spending. And to that end, we compared changes in the state of Oregon using Medicaid claims to the neighboring state of Washington. Washington is a nice comparison state in that it has similar demographics to Oregon. It has a similar sort of rural-urban split, similar penetration of managed care organizations, but it didn't have any major health reforms during the study period. So we looked at Medicaid claims in 2011, the year before the CCO transformation, and compared that to 2013, 2014, 2 years after the transition, treating 2012 as a transition year. And we looked at measures of spending, utilization, some measures of quality. Medicaid studies present a few challenges, and I'll mention a couple technical issues that we dealt with. First, there's a lot of managed care that happens in Medicaid, and so they often pay providers on a capitated basis. And so in this case, what you see is you see visits and encounters, but you don't see an actual payment. And so what we did here is we attached the Oregon fee schedule to all of the claims across both states, and in our paper we refer to this as standardized expenditures, so they're sort of common across both states. A second challenge is that the availability of claims and the way claims are coded can differ for some services. So in this case, mental health claims were not available for Washington. They're housed in a different area. And then coding for some things like ambulance transport really differed in a way between both states, made it hard to roll up all spending. So we focused on a core set of services, focused on physical health. So we looked at primary care visits, ED visits, evaluation and management visits, procedures, tests, imaging, inpatient care, sort of a core set of physical health services was rolled up as our main measure of expenditures. So what we found was that spending prior to the intervention was parallel in both Oregon and Washington, and that following the CCO intervention, spending was about 7% lower in Oregon. Most of this was driven by reductions in inpatient utilization, although we also saw some lower spending on evaluation management visits and lower spending on tests. We tried to assess some measures of quality, and we did see reductions in avoidable ED visits. We saw some improvements in some measures of low-value care, such as imaging for headache or unnecessary cervical cancer screening. And we saw a suggestion of a reduction in ambulatory care-sensitive hospitalizations, although this was only significant in the second year. We did see a relative decrease in primary care visits in Oregon compared to Washington, which is a little bit confusing at first, but I think that some context may help explain that. First, Oregon had a pretty high rate of primary care visits before the study, and even though it declined in some amount, it remained higher than Washington's in 2014. Second, Oregon had a very large increase in its Medicaid population during the expansion year, so there may have been some capacity issues in 2014. And third, the CCOs really did take seriously the notion that some of the way that they were going to change care was by focusing on social determinants of health. And so we saw a lot of investment in supportive housing and community health workers, and it may have been that these alternative settings or alternative ways of providing care substituted for primary care visits. So we saw this as sort of a good, promising start, early assessment of Oregon. To place these results kind of in the larger context, Medicaid, I think, can be seen generally as being a successful part of the Affordable Care Act, as being a large component of what helped the Affordable Care Act bring the uninsurance rate to the lowest that we've seen in 50 years. I think it's natural to look at the budget implications, and what you see in terms of Medicaid spending are perhaps a few responses. One response from some states is to look at using co-payments and cost sharing for their Medicaid beneficiaries, and although I think it'll be helpful to see the data coming out of those states, we should probably be cautious about requiring people who are at or near the poverty level to pay more out of pocket for their health care. A second approach that's embodied in some of the legislation that we're seeing last night is simply to kind of passively disenroll some people. That obviously costs less than covering them, but it tends to erode some of the coverage gains we've made over the last 3 years. But Oregon's model really suggests a potential third way, which is that delivery system, if sort of done thoughtfully and carried out the right way, may be one way of reducing budgetary pressures at the federal and state level, while still providing access to care and providing insurance coverage for a large group of people who otherwise would not have the resources to acquire insurance and the protections it offers. Thank you very much for your time.
Thank you for the opportunity for me to be here today. I'm going to talk briefly about our paper that looked at how the state of Texas used Medicaid payment reform to affect early elective deliveries of babies. So to put this in context, the U.S., as many of you know, has traditionally had one of the worst infant mortality rates in the developed world. And one of the reasons the U.S. rate is so high is because we have a relatively high preterm birth rate. And delivery prior to full term is associated with substantial perinatal harm, such as increased likelihood of NICU admissions, respiratory distress, ventilator usage, sepsis, and feeding issues. So as a result, in 2013, the Joint Committee opinion by the American College of Obstetricians and Gynecologists, or ACOG, and the Society for Maternal Fetal Medicine endorsed and encouraged revised term designations. So this next slide shows that the committee narrowed what's defined as full term from 37 to 42 weeks down to 39 to 41 weeks. So we went from 5 categories down to 3. And the reasoning for that was a lot of literature that came out in the mid-2000s suggesting that babies born even just a little bit before 39 weeks had worse health outcomes. So babies born at 38 weeks had 38% higher risk of some of these adverse effects when compared to babies born at 39 weeks, and babies born in the 37th week had 90% higher rates of these adverse effects, and that can be costly to the system in terms of higher NICU usage. So we're focusing on early term, so between 37 and 39 weeks, and we know that births sometimes just happen, and so we're splitting them off, looking at what's spontaneous, so the naturally occurring births, and induced. And among the induced births, there are some births that policy cannot affect. Guidelines won't change these. So induced births from medical necessity, so such as preeclampsia or fetal distress, placental problems, these aren't going to change based on policy, nor should they. There's been a focus then on the births that policy can affect, such as early elective delivery. So early elective delivery is defined as induction of labor and or cesarean section occurring prior to 39 weeks without a medical necessity. And the objective of our study was to look at, to examine the effect of Medicaid payment reform in Texas. And then the reason we're focusing on Texas is they were the first to do this policy on early elective delivery and other perinatal births among singleton Medicaid births. So we look at birth certificate data from 2009 to 2013. And the reason we start in 2009 is that's when they started reporting payment type on the birth certificate file. And we supplement our data with the area health resource file where we get some county level characteristics to make our models more precise. And our model is a standard difference in differences approach where we compare changes in birth outcomes in Texas to changes in outcomes in other states. And we use 3 different comparison groups in our paper. And the first is to compare changes in Texas to changes in states that did not have any type of collaborative effort in place. So an example of a collaborative effort that some of you might be familiar with is the March of Dimes It's Worth the Wait campaign. So that's they're providing education and outreach to both patients and providers on the importance of waiting until 39 weeks. And the problem with some of these, I shouldn't say problem, but the reason some of these the reason we were interested in comparing to states that did not, as well as states that did have these efforts, is that these collaborative efforts are voluntary, and they might be attracting the most motivated hospital systems or providers. So our 3 comparison groups were, 1, states that did not have these policies in place. Our second group was states that did have policies like this in place, or had changes in their Medicaid policy in place. Such as a soft stop Medicaid policy where they would reimburse providers the same rate for a vaginal as well as a C-section delivery. And lastly, the state of California, because it had similar pre-reform trends and demographics. So this slide shows the trend in early elective delivery over time. So in 2011, Texas launched the Healthy Texas Babies Initiative. And as you can see, I don't know if it's red there, the bill was passed in June of 2011, and it was implemented in October of 2011. And then the other 3 lines that are probably hard to read from there, or trend lines, show our 3 different comparison groups. So regardless, in terms of our results, regardless of which comparison group was used, we found declines in early elective delivery rates, ranging between 1 and 1.5%. Percentage points after reform. And then when we focus on the Medicaid births that would be affected by the policy, we find rather large gains in gestational age of about 5 days, as well as gestational weight of about 6 ounces. So in conclusion, we think that Medicaid payment reform was an effective tool at reducing early elective deliveries, and we have evidence to support, which I didn't get into today, that the effects were larger for both Latino births as well as non-Latino Black births. And then in terms of what we would expect in other states, it all depends on where the early elective delivery rate would fall relative to Texas, and also what other policies might be in place. So as an example, since I'm in DC, in our time frame, Washington's early elective delivery rate was 7.7%. And they did not have any other types of collaborative efforts in place. Florida and Kentucky are 2 other states that had rates similar to Texas, also without collaborative policies in place. So we would expect places like these to have much larger declines in early elective delivery rates versus some of the states that already are well below the sort of the benchmark level of 5%. So thank you.
All right, thank you very much again for the introduction, and for our hosts at Health Affairs for putting together such a great event and inviting me to participate. I'd like to acknowledge my co-authors, Hal Yee and Paul Gibney at the Department of Health Services in LA, as well as my colleague Atif Mehrotra at Harvard, as well as our funders for this project, the California Healthcare Foundation, as well as the Blue Shield Foundation of California. So, as many in the audience are likely aware, timely access to specialty care is an enormous challenge for patients in the safety net in the U.S. And we think of the safety net here as patients with Medicaid or without insurance. And it's generally felt that the shortage of specialists who are willing to provide care for patients with Medicaid or without insurance due to low reimbursement is a major cause of this problem. And as a consequence, in Los Angeles, this is an acutely this is an acute challenge for the Department of Health Services, which is the second largest public health system in the U.S., serving over 670,000 patients in their primary care population across 4 hospitals, 19 multi-specialty clinics, as well as dozens of community-affiliated practices. A couple of examples of how challenging specialty access was in the Department of Health Services. Prior to 2012, it was common for patients to need to wait 6 to 9 months to get even a semi-urgent specialty referral, like getting a colonoscopy for a change that was concerning for colon cancer, or getting an orthopedic surgery appointment for persistent pain or a concern for a fracture. And so in response to this crisis, the Department of Health Services implemented what they called the e-consult model in 2012. And to illustrate for you exactly what this new model meant, I'm going to contrast the old system to the new system. So in the old system, which is how many primary care doctors across the country work, your primary care physician decides that you need a specialist referral, and so they give you the number for a specialist office, and either the front desk calls when you check out of your appointment, or you call later, schedule an appointment in the next weeks to months, and everybody hopes that you show up and the specialist provides you the care that you're looking for. And hopefully somehow the specialist communicates that back to the primary care doctor. Maybe they share an electronic health record, maybe they send them a letter. It doesn't take a lot of imagination to see how this could fall apart in many different settings, particularly among poor health literacy patients in the safety net. In the new system, what it does is the e-consult system shifts the burden of specialty care and the initiative from the patient to the primary care provider. And so in this situation, if the primary care provider decides that a patient needs a specialist referral or some question answered, instead of just giving you a phone number, what they do is they go to a web-based portal and enter what we call an e-consult, which is basically a standardized set of clinical information that's meant to communicate to a colleague, a specialist reviewer, everything that you would want to know to triage that specialty question and help figure out what's the best next step. And so once a primary care physician sends that e-consult, then a specialist reviewer will generally respond to it within 1 to 2 business days and can either initiate an electronic dialogue around how this can be managed, likely without a specialist visit in person, or as is the case for the majority of specialist visits, just route it to a centralized scheduling center to get in touch with the patient directly. In our study, what we were interested in doing was to collaborate with the Department of Health Services and examine what was the pattern of adoption of this e-consult system across the entire Department of Health Services system in the first 4 years of its implementation, and how did patterns of e-consult use vary during this time, and was it associated with sustainable changes in access? So, what you can see here in our first exhibit is this is the pattern of adoption over the first 3.5 years of the program. And what you can see is from the end of 2012, when the program was implemented, and naturally there was very little use, to the end of 2015, there was a steady and rapid increase in the adoption of this technology across the DHS system, with an average of 12,000 monthly e-consults by the end of 2015. And this was used by over 3,000 clinicians by the end of that period. And this is just to give you a sense of the scope of this program and the wide system it was adopted within. You can also see 2 lines below the top curve, which is DHS providers and non-DHS providers. And what these 2 curves show is the adoption within the DHS system, where e-consult was used for all specialty care, as well as adoption outside of the e-consult system, where, outside of the DHS system, where community-affiliated providers contracted with DHS to provide e-consult for their residually uninsured patients. We had several other key findings. So one is that despite this enormous growth, one might imagine that other systems might bend and break underneath the enormous fragmentation of 3,000 providers demanding specialty input at the same time. But we found that the median time to first response at 4 years after implementing this program remained 1 day, and that 25% of e-consults were still resolved without a visit. And it was interesting that actually the likelihood that an e-consult could be resolved without a visit was highly dependent on the reviewer you had within a specialty, despite having similar case mixes and caseloads among specialist reviewers. And most importantly, what we found was that from 2014 to 2015, there was a 17% decrease in the median wait time in this system, with chronically high wait times associated with the implementation of e-consult. And that one might think that this decrease in wait time and the access to specialists might release pent-up demand among PCPs and result in a surge in face-to-face visits for patients. But what we found instead was actually there was a stable volume of monthly face-to-face visits across the system. So what are the implications of this experience in the Department of Health Services? We think this shows that improving specialty access in the safety net isn't necessarily an intractable problem that just simply can't be solved. With a true operational transformation in how specialty care is delivered, I think DHS demonstrates that sustainable improvements in access are possible, and it's encouraging for other safety net systems looking to adopt technology like this. There still is a lot of room for improvement. So to give you a baseline, by the end of 2015, the median time to appointment for a patient was still 52 days, which is, I think a wait time that most of us would still be disappointed with, but it's still an improvement from the prior performance. And in the future, we'd like to explore how e-consult can be used in many other systems. Thank you very much for your time.
Once again, these presentations are very clear with respect to the findings. I want to try to put each of them in a tiny bit of context to the extent you all are able to do so. John, I'm struck, because my background, of course, is working in state health policy, I'm struck by the long history of policy leadership in the state of Oregon, and I just thought it was important, since you've got these positive results reported, that you perhaps expand a little bit on not just the model of ACOs on steroids, but some of the broader, longer-term efforts within the state that this initiative fed into, suggesting potentially the challenges and also the steps others might need to take if they wanted to achieve similarly positive results.
Yeah, so I'm not going to be able to do this comprehensively, but Oregon has a long history of experimenting with its Medicaid program, going back to the early 90s. Governor Kitzhaber was a two-time governor there, and he was the first to implement what is known as in Oregon as the prioritized line. And this was the first attempt to try to expand coverage by moving outside of the traditionally categorically eligible populations of Medicaid, and instead of trying to cover everything for a smaller group of people, to limit some services and cover a broader group of people. There were a lot of lessons from that, and what developed out of that was known in the state as the Oregon Way, which is efforts to bring people together, providers, advocates, and others, in sort of getting buy-in to developing the next stage of reform. And that was instrumental in developing the CCO model. So I think that's an important lesson underlying all of this, is that this wasn't just sort of bureaucrats flipping the switch, but really a lot of buy-in, a lot of discussion, a lot of grassroots efforts to try and get this right.
Thank you. Heather, you noted the high, the poor outcomes in Texas at baseline. You also mentioned it's the first state to move forward with this approach. I just wondered again if you can give a little context beyond the scale of the problem to what led them to go first, and the fact that other states have taken similar approaches. Just a little bit more of the ecosystem in which this initiative took place.
Sure. Yes, so Texas was the second highest in the nation in terms of EED rate, second highest rate in the time period that we looked at. And I think, I don't know a lot of the motivation, but I suspect a lot of it is that there's substantial harm and higher costs. And so what we're seeing now are some studies that are looking at the cost savings in the first 2 years of the program, and they are seeing fewer NICU uses and, again, savings from that. So Texas was the first in 2011, and there's 5 states that implemented the same policy in 2013. So did I answer your question?
Yeah, that's great. Thank you. Michael, you mentioned the way you characterize sort of shifting the burden from the patient to the primary care physician it's very evocative. I'm interested if you can say a little more about how that shift was received. On the one hand, I've certainly heard plenty of primary care physicians express frustration with the old model that you described quite well. The only thing you left out was the use of the fax machine, which I think is the primary form of communication. But in all seriousness, it's great to have your patient's needs met. It's also, these are clinicians who are already feeling the burden of electronic medical records and more paper and process, and I just wondered again if you could provide a little context on the notion of that kind of burden shift, which from the receiving end might feel like a very heavy lift.
Yeah. Great. It's an excellent question. I think it brings into relief the tension with delivery system innovations that, at the front line for practicing clinicians, you want an innovation to make it feel like you're actually making your job easier and not just simply piling something on saying, oh, patients are going to be better, but you have to do 5% more work for everybody. And so I think the key insight in terms of the context here for DHS is that they had a burning platform. So even though we're doing some qualitative work right now to really explore how primary care physicians perceive e-consult. And certainly this message is coming through that it really is a burden. But I think one theme that we're hearing is that it's worth the effort. That phrase keeps coming up over and over. And I think that's why we're seeing this rapid adoption in a system like DHS. But where I work, for instance, in Partners, it's going to be a harder sell to say, oh, look, you're going to do e-consult for all your patients now, and it's going to be amazing, but you have to do 10% more work for everyone. And so, because I think as a primary care doctor, you're also where the buck stops. So they see that when their patients are not getting the specialty care they need, they're the ones that also suffer because they can't help their patients.
Great, thank you. We have some time for questions. These are three really interesting analytic pieces of work, and want to make sure your questions are answered. I see someone here, and then we'll line you up in the back.
Thank you, Linda Brogowski from ARC. In terms of revising how care was delivered, it sounds like there were patients and there were doctors, but there are other parts of the care team in a safety net system. So I know with the CCOs that there were some flexing of the teams that came on. Could you talk a little bit about how physician extenders and other community health workers were engaged to help deliver more value for the innovation?
Yeah, I can try. There's a lot there. And so what you saw was a lot of experimentation across all 16 CCOs, and it happened all over the map. So it happened with ambulance transport, and so there were some that ended this sort of policy of you call, we haul, where you only get paid to take the patient to the hospital. So they would go to the patient and provide care there, and then leave and not take the patient in. The state wanted to employ and train 300 community health workers. I think they did over 1,000. Some of them are in clinics, some of them are in community-based organizations, so a lot of work for community health workers. Probably the month after the CCOs went into place, you saw in most of the hospitals a social worker who was sitting in the ED focused on the frequent flyer patients who are coming in and trying to grab them and put them in, sort of connect them with a primary care office. There was I think the most famous flexible health services story here was the notion that Governor Kitzhaber said, the old Medicaid system, if you had a patient with multiple chronic illnesses that were exacerbated by heat, and you had a heat wave, we would pay for multiple visits to the emergency department in the hospital. The new Medicaid system, the CCOs can pay for an air conditioner and sort of put that in place and resolve that. This was an apocryphal story, and I had my staff on the search for any air conditioner that would be bought, and there was one air conditioner purchased. I can tell you that did actually happen, but that was sort of the notion: is how do we go out there and spend spending? There is a study in Health Affairs last year that showed that there were efforts coming out of the CCOs to do supportive housing that brought people who were formerly homeless in, and looks like they got better care. So sort of all over the map, lots of experimentation.
Thanks. Here in the back.
Hi, I'm Nikki Garrow from the March of Dimes, and I have a question for Dr. Dahlen. In your analysis, were you able to look at policies that are non-payment based? Like you talked about the Healthy Babies Are Worth the Wait, but for example, hospitals that have hard stop policies, which in some states it may be all the hospitals, other states just some of the hospitals, and if you were able to account for that at all in your analyses.
We did not. We simply lumped them by either doing nothing or doing something. But that's a great question because there's quite a bit of variation. And so we were expecting to see a little bit more of a difference in our reduction of EED based on our two different comparison groups. And if you read the paper, they're very similar rates. But I do know that there's a lot of variation, even within states based on those different programs. So maybe next steps, if we look at a single state, we could do a little bit deeper dive with those unique collaboratives.
I just wanted to provide additional context that Dr. Lakey, who's the former state health officer in Texas, basically laid down a challenge to the whole nation to reduce EED, so that's probably one of the reasons Texas took the lead as well. Thank you.
Thank you. We'll take a last question here and then.
Josh Wiener, RTI International. So, question for John. So in the current environment, is what you described a block grant?
Well,
I think it's time to move to the next page.
Yeah, right. how much time do I have? Let me say the reasons to caution against this. So there was first of all, it is Oregon. It was the Oregon way. There was a lot of buy-in here. Second of all, there was, this is touched on the paper. I didn't talk about this a lot here. There was a very large investment from CMS, $1.9 billion to start this off. The state also had a SIM grant, so the state had a lot of help going in there. Third, there were certain things that were carved out of the CCOs, including long-term care, which is likely to get more expensive, and so this wasn't the whole package. Mental health drugs were carved out. And finally, this was sort of something that was going to be renegotiated every 5 years, and though I think this sort of the notion of setting a trend on spending and holding the state accountable is appealing, and it seems to have worked for Oregon. It was done in the way that we're going to review this every 5 years, and so in the middle of that 5 years, they had the new Hep C drugs come out. If you had set funding on a block grant and sort of trended forward, it would be hard to figure out how to pay for some of those things. So I think that there's lessons to be learned here, but it's definitely not a pill like we learned with primary care homes, or not, and definitely not a panacea.
And I'll just add, I've heard the air conditioner story for like 20 years. So I don't think it's unique to Oregon. We have 4 more terrific papers on Medicare, but please join me in thanking our panelists here on Medicaid. So we're going to keep moving seamlessly because it's we want to keep your attention. I know the content here will do so, but I want the flow to do so as well. Okay, I'm going to keep us on track here so that we have sufficient time for these 4 papers, all of which are looking at various delivery system innovations that were implemented through the Medicare program. If I could, thank you. We're going to hear from Maria Alva, health economist at RTI International. We'll hear from Sarah Ruiz, senior scientist and program officer at the Administration for Community Living, National Institute on Disability, Independent Living, and Rehabilitation Research. Erin Murphy-Colligan, social science research analyst at the Centers for Medicare and Medicaid Services in the Center for Medicare and Medicaid Innovation. Melvin Ingber, a principal scientist at RTI. As I say, each of these are presenting papers on innovations occurring through the Medicare program. I'll turn it over first to Maria.
Okay. Thank you. So, diabetes affects 25% of individuals in the United States over the age of 65. And the estimated cost of diagnosed diabetes equals $245 billion a year. In spite of this, we see very little evidence of governmental interventions geared towards staving off the cost of diabetes. So today, I am going to talk to you about a study I have conducted with colleagues at RTI that look at whether or not the YUSA diabetes prevention program has reduced medical expenditure and utilization. We find that not only the program saves money, but it also has a positive return on investment. So, epidemiological data from other studies has shown that the risk of diabetes increases with higher levels of BMI. There is mounting evidence that shows that lifestyle interventions can help in reducing the onset of diabetes and delaying as well the incidence of diabetes. For example, people who participated in the DPP trial, which is a similar similar program to the one we're studying. So the trial shows that people who were randomized in a lifestyle intervention over 3 years have a 58 lower incidence of diabetes compared with people in usual care. It is unclear, however, whether weight loss intervention can yield reductions in medical expenditure. So the YMCA received a $11.8 million award from CMS to recruit people with prediabetes over the age of 65. The goal of the Weil model is to help participants lose at least 5% of their body weight and to gradually help them increase the level of physical activity up to 150 minutes a week. So the program lasts overall a year. The curricular comprises items like exercise sessions, nutrition information, as well as a motivation component, strategies for motivation. And after these weekly 16 sessions, follow maintenance sessions, 8 monthly maintenance sessions. So the goal of our study was to establish whether this diabetes prevention program really reduced healthcare spending and utilization among fee-for-service Medicare beneficiaries. So more than 8,000 people nationwide participated in this program. We were able to collect information only for 3,319 of these individuals, either because we couldn't link their claims data or because they were Medicare Advantage participants. The program started enrolling in January 2013 and carry on enrolling participants up to June 2015. For every participant, we were able to obtain 2 years of pre-innovation data, so we were able to observe the trends, and so we were able to ensure that we match individuals in the program with non-participants with similar trends, so we do a diff analysis. And we use claims up to December 2015. So it means that at least we're able to collect 6 months of post-innovation data, and at most we're able to collect 3 years of post-innovation data. So as you can see, 70% of participants were female. 53% of participants completed at least 16 sessions, which means that they completed the program. And on average, people lost 9 pounds, which is roughly 5% of their initial body weight, as measured at the last session. So we didn't have random assignment in this study, so we use econometric methods like propensity score matching to select a group of a comparison group with similar characteristics as the participants. So comparison group members had to have prediabetes, had to live in the same geographical areas as participants, and have to have similar characteristics and similar spending and utilization patterns prior to the intervention. Overall, we matched very well our group of participants with the controls, and especially interesting to note that both the treated and the control group had significant lower spending than the average Medicare person. So here are our findings. This figure represents the change in spending, so a negative number represents savings. Savings were the highest in the first year, and they amounted to $364 per person per quarter. The impact of the program decreases after that. But we found that over the 3 years of the study, the weighted average savings amounted to $278 per person per quarter. We found similar statistically significant impacts on inpatient visits and ED visits. Over the whole 3-year period, we find 9 lower inpatient visits and 9 lower ED visits per 1,000 participants per quarter. So in conclusion, our main finding is that the YMCA diabetes prevention program was associated with a significant reduction in spending and utilization per participant. We find that the biggest impacts happen in the first year, that is when participants are actively engaged in the program. The final point is that results from the first 2 years of this innovation inform CMS policy decision
to, for the very first time, include diabetes prevention program as a covered benefit. The proposed date was January 2018. Thank you.
Thank you so much for having me here today. I'd like to acknowledge my co-authors, Lynn Page Snyder and Christina Rotundo of NORC at the University of Chicago, and Caitlin Cross Barnett, Erin Murphy Colligan, and Catherine Jericchio of the Center for Medicare and Medicaid Innovation. This work was completed while I was at NORC. While many acknowledge that high-quality home visit programs improve health and quality of care for older adults, the evidence base is mixed, with stronger results, more positive findings for younger study populations than older study populations. Home visits are distinct from the Medicare home health benefit that provide professional care following a hospitalization. They offer a bridge to primary care, and they offer support and the opportunity for consumer engagement. Our mixed methods evaluation focused on 5 programs, and for more details on this program and methodology, please see the paper. The Aging Brain Care Model in Indiana, also known as ABC, that provided support for older adults with dementia and/or depression. Sutter Health's Advanced Illness Management Model, or AIM, that provided care to older adults in the last year of life, so they had a physician's prognosis of death within 12 months. Community Aging in Place, Advancing Better Care for Elders, by Johns Hopkins University, known as CAPABLE, that provided supports to age in place for dual eligibles in Baltimore, Maryland. Doctors Assisting Seniors at Home, or DASH, another program in California that provided care to preempt emergency service need. And finally, Stroke Mobile within the Ochsner Health System, which provided care for older adults following stroke. Our data for this project included Medicare fee-for-service data. We used a difference in difference analysis. We looked back 2 years prior to enrollment in the program and up to 3 years after enrollment for both treatment and comparison patients. And we also had qualitative data through multiple rounds of site visits, focus groups with both patients and family caregivers, and document review. The high-level quantitative findings are, we found 2 of the programs made significant reductions in Medicare expenditures relative to matched comparative patients. DASH reduced hospitalizations and ED visits. Stroke Mobile reduced readmissions, and we did not see any significant findings on the claim side for the ABC program. So, what's accounting for, what do we think is improving or is reducing costs for these populations? So in addition to reductions in healthcare utilization and costs, we observed improvements in patient-reported quality of care. As you can see, there was at least 1 improvement reported for all programs. So for example, all programs reported improvement in chronic disease self-management. 1 capable participant reflected, "It didn't stop on the last visit because I carry out what I was taught. What I learned helped me to move around more and stay active regularly." 4 of the programs, Capable, Stroke Mobile, DASH, and AIM, all improved health behaviors related to managing their chronic condition. Also 4 programs, ABC, Stroke Mobile, DASH, and AIM, improved communication with physicians. So as an AIM or other care team members, an AIM participant noted, there are no gaps when I have to call and ask what happened. I get fast replies from my care team. And from the focus groups we had with family caregivers, we found reductions in caregiver burden for ABC, DASH, and AIM. So in conclusion, we see 4 of the 5 home visit models were associated with significant reductions in either healthcare utilization or cost relative to comparison groups. And we believe that care coordination and consumer engagement are what contributed to this improved quality of care. For it's a very diverse set of patients with multiple chronic conditions. However, we don't see a single component that was driving these reductions across the 5 programs. Together, I think these favorable findings from these home visit models help build the evidence base for the value of home visits as a bridge to primary care, and for this particularly costly and high-risk segment of the Medicare population. Thank you.
Good morning. Are we switching the slides? Yeah. Oh, okay, sorry. Oh, here we go. Great. Thank you. So today I'm going to be presenting on end-of-life outcomes for 3 of the Healthcare Innovation Awards that focus on cancer care. Before I begin, this is just our little CMMI thing. That's what we do. Have to put this in all our presentations. Just to give a disclaimer, the views expressed are my own and not those of the Department of Health and Human Services, and we acknowledge that end-of-life care is a sensitive issue, and HHS does not support withholding life-sustaining treatment against the wishes of the patient. So just wanted to make sure that was clear before I get into our results. To give a little bit of background about the problem, as we all know, end-of-life spending is very expensive, and especially so for cancer care. And by the year 2020, we'll have 1.2 million people in the last year of life with cancer in the Medicare population, and the cost will exceed $50 billion. That's supposed to be billion, not million. I'm going to blame the pregnancy brain on that mistake. But a lot of this spending at the end of life is driven by ED use and hospitalizations and intensive care unit stays, which are very costly. And a lot of that intensive medical resource use is avoidable. And so it represents an opportunity for improved quality and reduced costs. And equally, if not more important, patients actually tend to prefer less intensive treatments at the end of life and more palliative and spiritual resources. So what we did was we took 3 programs within the Healthcare Innovation Award portfolio that focus on cancer care. One being the Come Home model, community oncology medical home model from the Innovative Oncology Business Solutions, which had 3 components, triage pathways for nurses and physicians, as well as extended hours. Patients could go to see the physician after hours, nights and weekends, and they had access to a triage line. Excuse me. And the triage pathways were based on national clinical guidelines. The Patient Care Connect program out of University of Alabama at Birmingham used a patient navigation model, wherein patients would be paired with navigators that would help them navigate their healthcare system, connect them with resources, and act as a go-between between them and their providers. And thank you. And they also used the Respecting Choices model to help patients with advanced care planning. And the Care Track model at the University of Virginia was actually the only one of these 3 models that solely focused on patients at the end of life. But in Care Track, patients would be administered the PROMISE survey, and nurses would use that information to basically triage patients to their physicians if they were reporting exasperations and symptoms, so that the physicians could provide more palliative care services. The study design was a retrospective cohort study, looking at study participants that passed away as well, and comparators that passed away in the year before death. And our main data source were fee-for-service Medicare claims from the Chronic Condition Data Warehouse. The study population was basically all participants that entered these programs between the award period, which was June 2012 to December 2015, and subsequently died before December 31st, 2015. Our sample size was about 1,200 for Come Home, about 2,200 for PCCP, and 60 for Care Track, which was a smaller study sample. And our comparison group were propensity score match Medicare fee-for-service bennies that were served by similar practices to the practices that were included in the interventions. The measures we looked at were hospitalization, emergency department visits, Medicare spending, as well as use of chemotherapy and hospice in the last 14 days of life, which are both NQF-endorsed quality measures. So these are the cost figures here. As we can see, both Come Home and PCCP were associated with reduced spending in the end of life. The savings amounted to about from between $1,000 to $5,800 per patient for the Come Home program, depending on whether you're looking at 30 to 180 days. For PCCP, the cost savings were between $2,700 and about $8,000. We didn't observe significant findings for CareTrack, but we did see trends in the direction that we had hoped, but likely we weren't sufficiently powered to detect cost savings. And this amounted to about 6 to 18% savings overall relative to the comparison group. In terms of utilization outcomes, both Come Home and PCCP had reduced hospitalizations. Come Home had 57 fewer hospitalizations. There should be little stars there. PCCP had 40 fewer hospitalizations and 60 fewer ED visits per 1,000 patients in the last 30 days of life. And again, we see positive trends for CareTrack, but we actually did not detect any significant savings for CareTrack. It looks like there was increased utilization, but again, we just had a very small sample size for that particular program. And finally, looking at hospice use and chemotherapy at the end of life, PCCP participants had 85 more patients enrolling in hospice per 1,000 in the last 14 days of life. And there were no significant findings for the other programs. We didn't have a sufficient sample size of patients using chemotherapy to run these numbers for CareTrack. But again, we did see encouraging trends as far as hospice enrollment in all of the programs. So I guess the key takeaway points from this are that in all of the interventions, the one thing that they sort of had in common was that they had access to providers and navigators after hours that would sort of help them work through their symptoms so that they didn't have to necessarily go to the emergency department. They had the opportunity to manage their care and manage their symptoms in less intensive settings. The results are especially important because, as many of you know, the CMS launched the Oncology Care Model last year, and that model incorporates a lot of the interventions that these programs implemented. It has elements of the oncology medical home as well as patient navigation. And so OCM provides a potential payment mechanism to support some of the interventions that these awardees implemented. However, it's still unclear how lay navigators like those employed in PCCP would be reimbursed under traditional Medicare payment policies. So definitely, I think we'll all be looking to the results of the OCM evaluation to look for clues and how these models could possibly be scaled up on a wider scale. So thank you.
Well, now that you've seen the first slide, you know the story. So there was an initiative at CMS to reduce hospitalizations that would be avoidable for nursing home patients. And the nursing home patients in question were long-term care patients. They were most concerned about that. So the office at CMS called MMCO, the Medicare Medicaid Coordination Office, alias the Duals Office, designed this intervention to go out to help nursing homes do better. The evaluation that we worked on was sponsored by CMMI. What the problem was that they were perceiving is that they could, from past experience and other publications that had been put out in the literature, they knew that it was possible to reduce some avoidable hospitalizations because these hospitalizations are dangerous for people if they are not really for something serious. There are iatrogenic effects, and patients come out with a hospital delirium and all sorts of problems, especially at the nursing home stage of life. Most of them are elderly people. So the question is, how much could you do in the facilities and change facilities in a way to reduce the numbers? So we were sent off to evaluate this using all the data we could get together. And since this was dual eligibles that we were mostly working with, there were some small proportion of Medicaid only out there, but they were mostly dual eligibles. We mostly looked at Medicare data. And the that was going to be in the evaluation phase. I'm going to tell you a lot about what was actually done because that's key to interpreting anything we found quantitatively. So well, it wasn't CMMI, but MMCO went off and solicited proposals from organizations. Anybody want to play? Send in a proposal. What would you want to do to go off and help nursing homes? And they had certain things they had to do, and there was a layout of possible interventions they could do, and they had certain things they had to do organizationally. And they ended up picking 7 organizations, which were sprinkled around the country, 1 per state. They were Alabama, Indiana, Missouri, Nebraska, Nevada, New York, and Pennsylvania. So there were a lot of differences, leading us to want to do within-state evaluations because they're so different, the states themselves. So when they picked the 7, these guys were supposed to then go out and set up an organization, hire staff to go into nursing homes to actually implement things. And also, they were supposed to recruit, and did, nursing homes to play. And these were then volunteers who agreed, in fact, to work with them in this. And the term volunteer could mean a lot of things. It could mean that the actual facilities wanted to do this in a really big way, and that could affect the way they behaved. Unfortunately, volunteered sometimes meant somebody in the corporate office volunteered you. So the term volunteer actually has a real mixed meaning here for how they behaved later on, and our teams were out there looking at the volunteerness and resulting behavior. The interventions that they were supposed to bring in fell into a bunch of categories. Clinical care and assessment of residents was a big one. Send in skilled nurses, NPs, nurse practitioners, to literally work with the residents alongside the nursing home staff. That was one potential intervention. They didn't have to do that, and some places did not. Education of facility staff was a major component of everything. Education in different dimensions, but education about seeing changes of condition in patients early and how to treat them. That some ways was only education about how to use tools to actually communicate. So using the tools, the so-called, in this particular case, we're talking about Interact tools. These are either paper or computer-based devices for aiding communications. They also were doing medication management, end-of-life planning, and introducing IT in some cases, although that's a very mixed bag because nursing homes don't have very good internet, they have poor wireless, there were all kinds of interesting things going on. So what actually happened out there? Well, we had big teams visiting them to find out, and things moved rather slowly. They started up in 2013, phasing in things. So when we examined 2013, we didn't find too much in our quantitative findings. We were not surprised. And the challenges that were faced that slowed things down a lot, even through the whole program, buy-in by facility leadership was a mixed bag, in fact. And in fact, it changed all the time because facility leadership changes all the time. Nursing homes have a characteristic of turning over the administrators, the directors of nursing, the nurses, and the certified nursing assistants. Everybody's moving. And so what they had to do was keep re-educating. These were all very difficult things to deal with. The other thing that really was found was that people matter. People didn't get along with one another. One very nice nurse practitioner would go in, and it was like Nurse Ratched had showed up to help them out, and it wasn't working too well. So there were difficulties. So when we try to interpret our findings, it's within this context of extreme variability by facility, by program that they were implementing, and by state in general. So what we did, and we'll look at some of our results, which I know look like little dots and bars as usual. You can see that in these particular dots and bars, we're looking at the probabilities of any admission for these patients, all causes. And on the right-hand side is the ones that have been designated as potentially avoidable. So the probability, of course, the raw data are that there's a much higher rate of all admissions than there are of the subset. So we're looking at smaller numbers on the right-hand side. You can see that in almost all cases, the numbers are below the zero line, indicating there was a reduction. But the 90% confidence intervals show a fair amount of dubiousness. So one of the states that looks really good is Nevada. I would be real careful about that because the way we had to do the analysis, aside from a bunch of fancy regressions, was to match a comparison group. And Nevada, we couldn't match because there were so few facilities in Nevada, we couldn't pick and choose. We had to take all the leftovers. So Nevada results are a little bit sketchy. But you can see that in the others, and in particular, as we'll point out, the ones that are having the largest effects are the ones with the hands-on nurses and nurse practitioners. The education was helpful and working, but had to be run all the time. But the more intense the actual clinical intervention was, the stronger the effects were, basically. So we look now at dollars, and you see more or less the same pattern of some of them much stronger than others. And that holds even for the avoidable ones, which have a smaller number. It's hard for you to tell quantitatively what's going on, either the dollars or the probabilities, but if you get a 2% reduction in some of these things as a percentage of what's actually going on, 2 percentage point reduction, it can be a 20% reduction in per person year rates of this sort of stuff. So because time is out, the final words are that there's a good deal of variability in what's going on in these top-down interventions. The nursing homes had no financial incentive in this at all. And so it was a matter of changing cultures, and the states varied, the actual interventions varied, the consistent, more consistent clinical care, the ones that were more sparse showed a smaller effect, the ones that were more intense showed a stronger effect. And changing culture in these facilities is difficult. Nobody is trained coming into these facilities to know what it is they're bringing in the intervention itself. They don't look at it the same way. A lot of these people are not trained even to do long-term care, the people going into facilities, and so they don't really understand. And lastly, I'd like to thank these 4 million people who actually did a lot of the work on this project. Thank you.
I'm going to start off with a couple of overarching questions, because again, I think these papers have been, the findings have been presented very clearly. So it's really not fair to pick on Mike Chernew since he had to leave, but he did leave us with many things to think about, including the phrase that if you want to save money, you shouldn't spend money, you should save money. It does seem like some of the findings presented in this panel lead us in a slightly different direction, because it does seem like there was spending and savings. And I just wonder, my sort of tentative hypothesis of how to balance his statement with the findings here is it really depends a lot on what you're spending the money on, and particularly how expensive the interventions are. And if you give a bunch of money to very high cost centers, you can run through your savings really fast. I just wonder if any of you had reactions to juxtaposing his phrase with what you found in your work. Anyone want to take that on?
Sure. The intervention in our study is about prevention, which is something that often we don't do. And I think it's interesting that most of the evidence that we have been having over the past 20 years has been good, but apart from the big trial that I mentioned when I was explaining our results, almost all the evidence, the positive evidence, comes from small studies. And so I think perhaps for that reason they haven't been historically taken seriously. And also I think the fact that in this setting, taking aside the Medicare fee-for-service patients, if these results are extrapolable in other populations, the idea was that these savings could happen in a very long term. So for diabetes patients, you think about big savings happening from avoiding acute events like heart attacks or amputations, and that happen. People think that this happened later on. Instead, in the study, we find the biggest impact is immediately, and so I think insurance companies may think that it's not worth investing in prevention because they cannot lock their customers long term. People can shop around every year, so they never will internalize this cost. And so it's important to have big studies like this one that we're lucky enough to be funded and to be evaluated that not only have a really big sample size, but also follow people from a very long period of time.
Sarah?
This is one of my favorite topics. We don't present on it on the paper, but because we don't have cost of program data on all of these models. However, the actual outcomes of these models paint an interesting picture about sustainability and scale-up efforts of programs. So one of the models capable, we do know the program costs, and so if you look at the savings, there is a possible ROI there. Another one of the models, ABC, where there were not significant findings, they actually have partnered with local and commercial agencies you can purchase a program and implement it locally. The remaining program, it's a mix of efforts to partner with local agencies, and they have a general sense of how much things cost, but not a specific per person. But the AIM program is that what they offered as part of the CMMI model is actually part of their system. That's something that they were committed to at the onset, and so they're continuing it. So I think they had a pilot study where they had seen the ROI there, and that was enough organizationally to kind of push them forward. So I think it's, at least within the home visits, it's a mix of showing evidence that's showing that there's reductions in costs that could actually fuel offering more, and those that even if they don't necessarily see the evidence, seeing other quality of care outcomes that would encourage the organizations to continue offering the program beyond.
Thanks. Similarly, of the three programs that we profiled here, the Come Home model did actually achieve return on investment on the overall model. So not just looking at our subgroup analysis, but in the main report, which was published, our contractor NORC did all the analysis, and they were just published on our website yesterday. So if you go to innovation.cms.gov, you can find the report, which includes the evaluations of all of the Healthcare Innovation Awards, and in our portfolio, the Come Home program did achieve a return on investment when factoring in all the program costs as well as the costs of the actual Medicare grant. So we didn't see significant savings overall for the other two programs for their general populations. We just observed the savings within the end-of-life care, within the decedent subgroup analysis. But yeah, it's definitely a challenge. You do, especially with lay navigators, because there's no way to reimburse them currently. So it's a huge challenge as far as how to keep these programs running and how to make that initial upfront investment without that support. The oncology care model includes some elements of bundled care as well as some shared savings elements. So I think that'll be a really good indicator as to how we can basically make these programs sustainable in the long run.
With respect to the nursing homes, you can see a return pretty quickly if you're doing it differently from the way it was implemented here, which was a major organizational situation. But when you determine which parts are working best, those could presumably be implemented at a lot lower cost. But changing the minds of physicians who don't trust the ability of the nursing home to handle the patient and keep them in, that's a major issue that they ran into, and it showed up over the entire span of time. There were always some people who said, call me up, there's a problem, send them to the hospital. Then there were families who say, send them to the hospital. So it's not so easy. But the more time they spent, the RNs and whatnot, and NPs, with families, the more understanding there was, in fact, about the non-necessity. So it's a bit of a long process to get the money, but you can make a pretty quick dent if you've got somebody on the floor of the nursing home to help.
What questions do we have here? I'm going to see if anyone other than Mike who's asked one, but I'm happy to call on you again if you're alone, and then I'll close with mine. I was holding it to see what was out here. But
just very, very quick question. Thanks, Alan. For Erin, I've heard people talk about how much is spent on end-of-life care for many years. There was an old study that I think said that the percentage of spending on end-of-life care, whether it's last year or last 6 months, hadn't changed. I wondered if that was something you looked at or had any more updated information about. Thank you.
No, we didn't look at that. You mean the percentage relative to the other patients that were?
Percentage of Medicare spending on?
Or total health spending or total life of spending in one person's life. There's lots of ways to look at it.
Yeah, we didn't do that within these evaluations, but no, it's a really good point. Definitely worth more consideration.
You'll have to wait for our issue on the topic of end of life coming out later this year. Let me just close, since it went nicely down the line here, with two threads that I want to pull out. One is the role of consumer patient engagement. I'm returning a little bit to the prior theme about spending to save, that engaging patients is a new resource or an underutilized resource that doesn't cost the healthcare system any and can yield positive results. Obviously, it takes effort, significant effort to do it, but it's different in kind than some of the other models. And also the role of financial incentives at different levels, and just sort of ask as a closing thought for anything that you would want to add on the role of either consumers and patients or financial incentives to the results you found, and we'll close it out with that. So I'll take it again down the row, Maria, if you don't mind starting.
Okay, so in the case of the diabetes prevention program, I think motivation plays a huge role. So there is self-selection into the program, and if you look at who are the people who decide to self-select into the program, they tend to be healthier individuals. They tend to be predominantly women, and so if you think about the issue of sex selection, we match a sample the best we can based on observables, and it looks all good. But if you think about the patient engagement, I think perhaps there is an argument for thinking that people who will enroll in these programs will anyway tend to do better than average because they have the drive and motivation, which are all things that are difficult to capture.
So I didn't get into the workforce findings for this, but the workforce that led the home visits were lay health workers or RNs, sometimes a combination of both. And what we heard, we did have some workforce surveys. What we heard again and again is that obviously that first visit really provided a window into what the barriers were to adherence to the treatment plan, and also kind of gave them some goals to work toward over the period that they had the home visits. And I would say in terms of consumer engagement, over time, the home visit staff consistently reflected to us that they were surprised that by the end of the program, they were noting changes. And some of these changes were they're multi-generational in nature. So going into the home visit, they were able to see some barriers, things like multi-generational smoking cessation that could help improve outcomes. But they they were surprised that just having that repeated touch and being able to take that information back to the care team, having that message reinforced during regular visits, really did have a big impact on adherence and some of those other outcomes.
So in the three models that we looked at in this paper, all of them had, the commonality of patients were more engaged in that they had more access to providers and could sort of troubleshoot their symptoms without having to wait for a costly medical encounter. And we didn't report on the qualitative findings here, but patients really felt empowered by that and felt like they had the opportunity to, run their symptoms by somebody who could give them more attention and help them avoid emergency department visits. And that was definitely received very positively on the part of the patients and the caregivers. And as far as incentives, actually none of these programs had explicit incentives built in, but with the oncology care model, there will be those shared savings possibilities. I think that could definitely inspire a lot of providers to offer those more intensive, just a little bit more one-on-one treatment with patients so that they can help them troubleshoot their symptoms and, again, avoid having to go to the hospital or emergency department.
The patient engagement actually plays a part in the nursing home as well, in a different way. The one-on-one engagement was important in explaining to people why they shouldn't just rush off to the hospital all the time. And that's something that the nurse practitioner could do and did do, where the nursing home staff doesn't engage in that sort of thing. It's very parallel to end-of-life care. The end-of-life work that was being done by some of these places was also very much one-on-one, getting people to fill out the forms, the MOLST and POLST and whatever they were calling it in that state. There's a lot of discomfort in talking to people about that, and that's related to going to the hospital, a lot of it. So engaging people in a one-on-one, talking to them sympathetically, it takes time, but it's important.
Okay, it's been a full day. I want to remind you that this was only possible because of support from the Blue Shield of California Foundation, Colorado Health Foundation, Missouri Foundation for Health, and the New York State Health Foundation. We'll do this again for our next theme issue, but for now, please join me in thanking our final panel.